computer. Okay. Yep. Okay. And then let me put you back at the
Okay, good. Can you see my screen? Am I still on? Okay. Okay, so I think I will start, as I mentioned, by doing a brief overview on fecal incontinence and how we use biofeedback in fecal incontinence. And then I also have a lecture on the obstructive defecation, the dyssynergia patients with fecal incontinence. And then we can go a little bit into the protocols and how we actually do the biofeedback training. So I'm going to start out with the fecal incontinence. Okay, so just kind of as a brief overview, fecal incontinence is basically defined as the uncontrolled passage of fecal matter for at least a month in duration, in at least patients at least 4 years old. And fecal incontinence, it's a very distressful situation for people. It often leads to complete isolation, loss of self-esteem, and their quality of life is diminished. And a lot of times these patients have troubles admitting that they have a problem and even seeking medical help. And it's very hard to get some actual numbers on how many people have fecal incontinence because of this lack of disclosure. But in the United States, we believe about 1 to 7.4% of healthy individuals have fecal incontinence. And in the United States, we estimate about 50% of nursing home residents are affected by incontinence, and that's probably the #1 reason why their family members admitted them to a nursing home. It's very, very difficult sometimes to take care of these kind of patients. Let's see. And also this condition really it has significant morbidity, and it's very, very costly for our healthcare system. So the mechanisms of fecal the mechanisms for continence, they're disrupted when we have fecal incontinence, and it's usually not just one thing. It's usually multifactorial. So about 80% of the patients have more than just one abnormality causing their fecal incontinence. So it could be that they have a weak sphincter. It could be that they have poor mobility and they can't get to the toilets in time. So usually it's a lot of factors that cause this fecal incontinence. Probably the #1 factor for incontinence is obstetric injuries, trauma. So this injury could be with the internal and the external anal sphincter. There could be pudendal nerve injury, and this can be caused by forceps delivery, a prolonged second stage of labor. So it's that constant pushing against the pudendal nerve that will cause pudendal nerve damage, and then muscle weakness. The large birth weight or a large head will cause a lot of obstetrical injuries, and then also the occipital posterior presentation can cause a little bit of injury to the pelvic muscles. Also, perineal tears, so the 3rd and the 4th degree tears can cause fecal incontinence. And a lot of times these presentations or these injuries aren't really presented until for several years, because usually the patients are younger and they still have a lot of muscle there. But as the patients get older, after menopause and after we lose some of our muscle fibers, then some of these injuries will present themselves. So these mechanisms, it can be from neurological diseases. So neurological diseases can affect the sensory perception or the motor function. So some of these would be central nervous system disorders such as MS, dementia, strokes, spinal cord injuries. So that can cause the fecal incontinence. the peripheral nervous system, such as the cauda equina lesions or diabetic neuropathy, that changes people's sensation, so they can have fecal incontinence. So if you don't have the sensation that there is stool there, you're not going to make the right maneuvers to either defecate or prevent that fecal incontinence. Also some other things that can cause it are anal surgeries for hemorrhoids, fissures, fistulas, sphincterotomies, dilations. Those all can cause some sphincter damage. Let's see. Oops, sorry. Hold on a minute. Sorry about that. I forgot to turn off my phone. Let me do that right now. Okay. So let's see. So, and also if there's damage to the internal anal sphincter, that's probably a more serious condition, and there's probably less treatments that you can do if there's damage to that internal anal sphincter. So perineal trauma, hip fractures, that all can contribute to fecal incontinence as well. Skeletal myopathy as we get older, rectal prolapses, poor rectal compliance. So if your patients have any kind of radiation treatments for prostate cancer or uterine cancer, now the walls of the rectum are very friable and rigid, all sorts of colitis, ischemia, Crohn's disease. So if the rectum is very rigid, it's not going to expand and be able to hold that stool. So these patients are going to have pain and also fecal incontinence because they do not have that storage ability. And also, if your patients have incomplete stool evacuation, they can have overflow incontinence. So those are those patients who have this constant oozing of liquid stool throughout the day and sometimes at night. So the bottom line here is that there's lots and lots of mechanisms and factors that will cause fecal incontinence. So when you treat a patient with fecal incontinence, you have to kind of sometimes look at the underlying condition, or factors, what's causing this condition, because it's not just biofeedback that's going to cure these patients. You have to also look at everything else to help decide what's the best biofeedback training or procedures for your patients, and if they need some treatment in these other areas. So the clinical presentation, there's passive incontinence. That's the involuntary discharge of fecal matter or flatus without the patient being aware of it. So there may be loss of rectal perception. So they might have some neuropathy or their rectal anal reflexes. So if they don't really perceive that there is stool there, they're not going to make the appropriate maneuvers to either go to the bathroom or try to prevent their fecal incontinence. Usually with passive incontinence, there's sphincter weakness as well. Urge incontinence is the discharge of fecal matter when the patient is aware of it and they make active attempts to try to prevent that leakage. So with these patients, there's most likely weakness. They have anal canal sphincter weakness, and maybe with their resting and possible also their squeeze pressures. And they also may have decreased rectal compliance. So again, their rectum just is not accommodating. It's not opening up to accommodate more stool. And then also the other presentation is fecal seepage. So this is just kind of throughout the day, these patients kind of leak just a small amount of stool, usually after a bowel movement. So these patients can have normal evacuation and they can have normal continence, but probably what's happening is they're not totally evacuating all their stool. So they have a little bit of overflow. They may also have impaired rectal sensation. So they don't feel that stool coming down and they're not making the appropriate maneuvers to prevent that oozing of stool. If they have internal hemorrhoids, that changes their sensation in their anal canal, so they can have oozing as well. And usually with these patients with fecal seepage, their sphincter and their pudendal nerve function are usually intact. So the nerves are usually good. Okay, so like I said before, it's really important to look at how these patients are presenting and what factors may be causing their fecal incontinence to help them cure that problem. So one way that we can try to improve their fecal incontinence is with biofeedback. So biofeedback is basically what we call neuromuscular retraining. We're going to utilize either pressure sensors with your manometry catheter or with EMG sensors. And I have an EMG sensor here that I can show you. It's just it's a sensor with 2 active channels and then also a ground that's inserted into the anal canal. And we can look at muscle activity. So by using sensors, the patient can actually see what their sphincter is doing. And when they try to squeeze or push, they can see immediately what their muscle is doing. So that's why we call it biofeedback. They see what they're doing, they're seeing the muscle response. So they can learn through kind of trial and error how to squeeze that muscle better to see if they get the response that we want, tightening of that sphincter or relaxing of that sphincter. Usually biofeedback involves 4 to 6 sessions, and usually we span it over about 6 months. So initially you're going to see your patients maybe the first session, and then we'll see them about a week later just to really enforce everything that we taught them. And then we kind of break our sessions down to maybe once a month. But usually it takes about 4 months for us to see significant muscle change, building those muscle fibers. It takes a long time. So that's something we have to do with our patients, is really explain to them that they're not going to get better overnight. This is a long process. It took the muscle a long time to get this way, and now it's going to take a long time to get it better. So our goal with biofeedback is to improve muscle strength. We want to build muscle fiber, and we're trying to improve both the resting pressures of the anal canal, which is going to be primarily the external anal sphincter portion of that muscle, and also our squeeze pressure, which again is going to be the external anal sphincter and also the puborectalis muscle. We can also, with biofeedback, improve awareness of rectal sensation and improve the motor skills. So when there's distension in the rectum, a patient should be able to feel that. They should be able to feel volumes 15 milliliters and greater. But sometimes people stop recognizing what that sensation of stool in their rectum feels like. They may have had a mega rectum, so we are not stretching the nerves, or they may have a little bit of neuropathy, or sometimes they just kind of stop paying attention to what it feels like to have distension in the rectum. So if stool is in the rectum, the internal anal sphincter relaxes, stool starts to come down, and if they're not aware of it, they're going to have oozing of stool. So we can inflate balloons in their rectums to reteach them what it feels like to have rectal filling. And at the same time that they feel the rectal filling, they should be squeezing their external anal sphincter to prevent that stool from coming down. So we can improve this rectal sensation and motor skill at the same time to help them prevent that oozing. So when we do biofeedback, we're not able to generate new nerves. We're not improving the nerves. We're just hopefully building muscle fiber. And also, just by them using those muscles, they get a better idea of what it feels like, what their pelvic muscles and their anal canal kind of feels like. So because of that, they just have a better awareness of that area. So we're not improving sensation. We're kind of improving their awareness of that area. Okay, so how we do biofeedback is, I should go back. So as far as our patient selection, usually we select our patients by looking at their manometry studies. So most of our patients have had a manometry study prior to. There's some exceptions to that rule. So if a patient is maybe going to have prolapse surgery repair, maybe sometimes the surgeons would want the patients to do some biofeedback training prior to surgery, and then also after surgery to kind of help strengthen that muscle. So sometimes we will do biofeedback without any prior manometry studies. But in most cases, they'll have a manometry study because that way we can identify what area is defective, what mechanism is having problems that might be causing their fecal incontinence. So if we did an anal rectal manometry study and we saw that this patient had weak resting pressures. So usually with manometry, their resting pressure in the anal canal should be between 50 and 120 millimeters of mercury. If we saw those pressures less than 50 millimeters of mercury, then biofeedback strengthening exercises would be a good technique for them. We're trying to build some muscle fiber and make that sphincter a little bit tighter. If we saw, let's see, okay, I kind of went off my slide here. Okay, so and if a patient does present with a weak sphincter, chances are your patients are going to complain of the inability to control gas, to hold back flatus, liquid or solid stool. So our goal is just to try to, again, strengthen that muscle with these pelvic exercises. So if I looked at this, this example here on the left, this is a patient with really, really low resting pressures and also a really low squeeze pressure. So there's 4 channels here, posterior, left, anterior, and right. And we're in the high pressure zone of the anal canal. So our scale is 100 here. So this patient has pressures in their anal canal of around 20 millimeters of mercury. So really, really weak pressures. When we ask the patients to squeeze in this yellow box here, we barely see any pressure change. There's just a minute amount. So this patient, they're only 10 millimeters of mercury. So this patient would really benefit from strengthening exercises. This patient would be a little bit tough though to see improvement. We like to see at least some squeeze pressures, and 15 millimeters of mercury is very, very, very little squeeze pressure. So this patient would be kind of a challenge. It's going to be a long process for them to be able to build some muscle fiber, but definitely a candidate for biofeedback because the low resting pressures, the fact that the patient can squeeze just a little bit will make them eligible for biofeedback. If this patient could not raise the pressure at all with a squeeze, then they would not be a candidate. They have to produce at least a little bit of a squeeze pressure. The other instance that we may find on our patients is that they have early squeeze fatigue. When they squeeze, they should be able to maintain 50% of their initial squeeze pressure for greater than 30 seconds. So this patient produces a nice healthy squeeze. It's about 100 millimeters of mercury on this channel anyway. This is posterior left on our left channel. But immediately that muscle fatigues. They cannot maintain that squeeze pressure. So this patient would be a candidate for strengthening exercises as well. Try to build up muscle fiber, try to improve the duration of that squeeze. Okay, so patients, the others, so our patients that we're going to do strengthening exercises on, just to recap, they're the ones who usually present with flatus incontinence, oozing or fecal incontinence. Sometimes they could be aware of the incontinence, they may not be, but if we see weak resting pressures, weak squeeze, or early fatiguing squeeze, we're going to do strengthening exercises with them. So the next type of patient that we may see is our patients who do not feel rectal distension. So we inflate the balloon in their rectum with 15, 20, 30 millimeters of mercury, and they don't feel any change. So these patients, we're going to do sensory biofeedback training with them. We're going to inflate the balloons in their rectum to a volume that they can feel. And then we get them to focus on that sensation. And then we very slowly decrease those volumes, hoping that they're going to feel these decreasing volumes. And what we do at the same time is when we inflate that balloon, we want them to squeeze their external anal sphincter. So when you feel distension, you should squeeze your external anal sphincter to prevent that stool from coming down anymore. So we call it coordination retraining. They're going to feel that distension. They're going to momentarily, for about 10 seconds, squeeze our external anal sphincter and relax. It's because what happens when you inflate the balloon in the rectum. So this top channel here where my red arrow is, that's our balloon inflating in the rectum. On our top channel here, this is our posterior orientation, the purple channel. When you stretch the nerves in the rectum, the internal anal sphincter relaxes to allow the stool to come down. So if you did not momentarily squeeze right here, that stool is going to start to come down into the anal canal. So we're going to teach our patients, as soon as you feel it, I want you to squeeze that muscle. And so we should see a rise in pressure just for about 10 seconds as they're squeezing to prevent that stool from coming down. I'm going to go into these protocols a little bit more detail later. Okay, so another kind of potential patient is either pre or post-surgically. So if the patient has a sphincteroplasty or they have a rectal seal repair, low anterior resections, biofeedback can help these patients too. And it's really nice sometimes to teach the biofeedback, the Kegel, the strengthening exercises before they have surgery. Because sometimes before surgery, you have just a little bit more awareness of those muscles. Sometimes post-op, it's a little hard to squeeze those muscles if you're having just a little bit of discomfort. So I really recommend pre-surgery, like one session of biofeedback before surgery, and then maybe 6 weeks after surgery to continue these strengthening exercises. So they've shown that after sphincteroplasties, sphincter repairs, that the outcome is a lot more successful if the patients do strengthening exercises afterwards. Okay, another candidate that's really good for biofeedback is patients who have had a colostomy, and now they're thinking about doing a reanastomosis, so hooking them back together. A lot of times these patients will have a manometry study prior to the resection to make sure that the patient has good sphincter control, that they can squeeze, and that they have good resting pressures. Because if they don't, then if they connect they reverse the colostomy, there's a chance that they can have fecal incontinence. So if they do have a weak squeeze because of atrophy with having the colonoscopy for a while, if they have a little atrophy, then we can do or we see weak squeeze pressures, we see weak resting pressures. You can do biofeedback therapy on these patients to try to build up that muscle fiber before they reverse that colostomy. Okay, so as far as your patient selection, there are some prerequisites. You have to have a motivated patient. Like I said before, some of your patients, it's going to take maybe 4 months before they see some significant improvement. And this is really hard. Your patients finally get enough courage to talk to you about their fecal incontinence, and they want an easy fix. They want to get better tomorrow. So it's very important to have a motivated patient, to explain to them that this is going to be a kind of a long process to get better, maybe up to 4 months. Some people, especially with the sensory biofeedback, sometimes they get better almost immediately because, we're able to teach them that sensation a lot faster than we can build muscle fiber. But it takes a while. So we have to have a motivated patient. They have to do these exercises, these strengthening exercises, about 5 times a day. And each session only takes about 3 minutes. So it's about 15 minutes out of their day, but it still takes time. It still takes them to, they still have to make the time every day and to remember every day to do these exercises. Your patients have to have the ability to process instructions. So if your patients have dementia, Alzheimer's, they may not be good candidates. They have to really be able to really process these instructions and what they have to do at home and to understand these muscles that they're using. As I mentioned before, they have to have some ability to be able to contract that sphincter. So if we don't see any EMG activity with a squeeze or pressure with manometry, then we can't get that muscle any better. There's nothing for them to work with. If we do sensory biofeedback, they have to be able to feel at least 40 milliliters, that says millimeters of mercury, I'm sorry. They have to be able to detect at least 40 milliliters of balloon distension in their rectum. And the other important thing is you have to have a motivated healthcare provider. You know, your job when you do biofeedback is to be a cheerleader. You're motivating your patients to squeeze. You're really getting them to appreciate any little bit of improvement that we have to keep them motivated to continue doing the exercises. So we have to be cheerleaders and we have to kind of stand behind our patients. So the healthcare provider has to be engaged in all this as well. Oops. So poor candidates, patients with dementia, like I mentioned before, they just, you know, they're not going to be able to remember your instructions. It's really not very beneficial. Young children, less than 4 years old, they're probably not going to understand the commands of squeezing or understand those whole dynamics. Often severely depressed people are not going to be very good candidates because they don't have the drive sometimes or the energy to actually stick with this program. If there's severe damage to the anal sphincters, so like a 4th degree tear, or if there was some kind of a surgical trauma or patient had some definitely damage to the anal canal, and we have asymmetry, doesn't matter how many times you squeeze, you're not going to repair that scarred area, that damaged area of the sphincter. So, you know, the sphincter is a circular muscle. So if you have damage on one side, we call that a keyhole defect. But if you squeeze and do these exercises, that area here is never going to improve. When your patient squeezes, if you have a defect here, the muscle will actually widen. That defect will actually widen with the squeeze. So those patients are not going to be helped by biofeedback. But if that patient has surgery to correct it, a sphincteroplasty, then they would be a biofeedback candidate after surgery to try to improve that muscle. If your patient has really, really low internal anal sphincter pressures, so really, really low resting pressures, chances are biofeedback's not going to help them very much as well. But I always think, give it a try, because this is a very non-invasive way to try to get the sphincter better. So I think it's still worthwhile. And if nothing else, by trying to get them to squeeze, you may improve their awareness of those pelvic muscles and maybe even give them a second or two more warning to get to the toilet. There's another procedure that's done sometimes to look at pudendal nerve conduction. So as soon as you stimulate the pudendal nerve, the external anal sphincter should contract. If there's a latency, if it takes a while for the external anal sphincter to contract, those patients have some pretty bad pudendal nerve damage, and they may not benefit from biofeedback. Okay, so as far as the biofeedback protocol, the most important thing is patient education. You know, we teach them the anatomy and the physiology of that area. We show them kind of what their muscle is doing, their abnormality, and we compare that to what a normal anatomy looks like. So they understand, you know, how that muscle is functioning and what's wrong with it. We also do some baseline, get some baseline data. We look at their diet, we look at their stool pattern, and we look at their quality of life. And we use this information, this baseline information, to look at improvement from week to week or month to month as they have their sessions with us. And I have some examples that I'll show you, but we want to know what their diet is, because maybe it's their diet that's causing their problem. You know, if they have constantly runny stools, maybe they're lactose intolerant, and we need to address that. You know, maybe they're not getting enough fiber, and their stools might not be very consistent because of their poor diet. So We want to, kind of get some diet information and see if we can improve their symptoms just with their diet. We want to know, how often they have fecal incontinence. We want to know the consistency of the stool. We want to know if it's oozing versus full incontinence. So again, if their stool is just really, really runny, if they have diarrhea, then we also want to address that. We want to make the stool firmer because it's a lot easier to contain a solid stool versus a stool that's really loose or diarrhea. And we do quality of life diaries just to see if the patient's quality of life is improving as we do these biofeedback trainings. So, and it's just a very simple, I have an example later, but it's just very, very simple. On a scale of 1 to 10, how is this problem affecting your social life, your work? Can you get to work every day? Do you have to go home and change your clothes before you even get to work? So, and we use that scale to motivate our patients to keep doing these exercises, because if they come back to you and say, I'm no better, I'm still leaking 5 times a day, I had to miss 4 days of work this week. If you show them, well, last week you leaked 6 times a day, and now you're down to 5, that's significant. So we use those diaries to really give them motivation to say, yep, you're improving a little bit. We're on the right track. Keep up your exercises. So we're kind of, like I said, a cheerleader. We're motivators by just trying to give them hope that they're getting better and to continue with these exercises. We're going to explain the protocol to our patients. We're going to explain to them that it's going to take about 4 to 6 visits with you. Each visit takes about maybe 30 minutes, maybe 40 minutes. They don't last very long because your patients are actually squeezing and showing us, and we're teaching them these exercises. So it's a lot mentally for your patients to take in, and it's exhausting for them to squeeze and relax. So our visits aren't very long because they fatigue very, very quickly. We inform our patients that they're going to be performing these exercises that we're going to teach them in our session at home, and that they have to do these exercises 5 times a day to see improvement. And we also kind of get realistic with our patients. We tell them that it may take 4 months for them to see some improvement. So stick with this protocol. Your patients have to take ownership of this and stick with it. Okay, so then your patients are going to come back for repeat visits. When they come back for, did I miss a thing? Okay, so I missed something. So on your first visit, and I'm going to explain this in more detail too, but on the first visit, we're going to teach our patients how to do the exercises. And your patients are going to learn how to do these exercises by watching their muscle response on the computer program. So then we instruct our patients that they're going to go home, they're going to do these exercises 5 times a week, and then they're going to come back for repeat sessions. And when they come back for repeat sessions, we're going to make sure that they're compliant with the exercises. We're going to evaluate their diaries. They're going to go home and they're going to do a stool diary to tell us how many times they're leaking, what the stool consistency is. We're going to look at their quality of life to see if there's any improvement there. We're going to look quantitatively. We're going to put the tube back into their little bottom, this little tube back in their bottoms. And we're going to make sure that they're we're going to see if there's any improvement in their muscle. We're going to make sure that they're doing the exercises correctly. We're going to kind of reinforce that protocol with the patients. And we're going to give our patients motivation to continue and schedule a repeat visit. Usually the third visit is in about a month. If they're doing everything right at this second visit, they're squeezing appropriately, then we usually space out the sessions monthly. Okay, so some of the things that we kind of, our tools that we use with our patients is when we do our patient education, we're going to show them what normal versus abnormal looks like. So on the left, this is our patient's resting pressure before the yellow squeeze here box. So this patient has low resting pressures. This is probably about 15 millimeters of mercury. When the patient squeezes, they're only squeezing about another 20 millimeters of mercury. They should squeeze 100 millimeters of mercury. So it should go really to the top of our graph. So we kind of show our patients, this is what your squeeze is. This is what a normal squeeze looks like. So they kind of realize that their muscle really is weak. And this does give them motivation to do these exercises because now they kind of have a goal. I want to get my squeeze to look like this. When we, if your patient has a sensation, poor rectal sensation, and we're going to do sensation coordination exercises with them, then we show them, you know, I'm inflating the balloon here. What you should be doing when that balloon is inflating, you should be squeezing and you should feel this. And you're not feeling this rectal inflation. And then I show them that this is what it should look like when you feel that rectal sensation. You should be squeezing your external anal sphincter and holding it just for several seconds. And then just so you guys know that this is the internal anal sphincter relaxing in response to this rectal distension. So you have to squeeze to prevent that stool from coming down. So we're going to show our patients these examples. Okay, so to get now into the protocol, you know, our goal with the pelvic strengthening exercises is we're going to guide our patients to recruit their pelvic muscles, so their external anal sphincter and their puborectalis muscle, to produce a contraction, a squeeze. And we want them to try to squeeze and maintain that squeeze. So we teach them to, we kind of coach them really. We coach them to contract that muscle while they're watching the screen. So when they try to squeeze, they on the monitor, they should see their activity go up. And if they do, we're just saying, yep, you're using the right muscle. Do you see how this activity is rising on the graph? So we're always giving them feedback of if that they're contracting the right muscle. The other thing that we want them to do or not do is to use any ancillary muscles. So when they squeeze to do these strengthening exercises, we only want them to squeeze their pelvic muscles, their external anal sphincter or their puborectalis muscle. We don't want them to hold their breath or use their abdominal muscles or squeeze their gluteal muscles. So the whole body needs to stay relaxed and just isolate these pelvic muscles. So we teach them not to use their abdominal muscles. So, and just to kind of back up too, so the protocol with these squeezes is they're going to squeeze their anal canal muscles, external anal sphincter muscles, and they're going to hold it for a count of 10. And then they're going to rest for a count of 10, squeeze for 10, rest for 10, squeeze for 10, rest for 10. So we're just using those muscle fibers. And I explain to my patients, it's like lifting weights with your arm. You know, you're using that muscle. So if you use that muscle, you're going to build some muscle fiber. So by squeezing your anal canal muscle, you're using that muscle and we're going to build some muscle fiber. So so our probe is in the anal canal, our EMG sensor. So this one here is in the anal canal. On your EMG sensor, there's an arrow. You probably can't see it on here, but there's an arrow that needs to point posteriorly. So every time you see your patients, the reference is going to be in the same spot. So we insert our EMG catheter into the patient's anal canal. The other, we have two channels. Our other channel, and then this is our EMG device. So our EMG device has two channels. So one channel is going to be surface electrodes. So we have 3 surface electrodes that we're going to put on the patient's ancillary muscles. So if you notice that when they squeeze, they really use their abdominal muscles, we're going to put these patches on their abdominal muscles. So 2 will be on either the left or the right side of the body. The white and the black will be on one side of the body, kind of around the obliques. And then we have a ground. The green will be the ground. So if your patients, when they squeeze, they're using their gluteal muscles, you can put these patches on their glutes. If they're using their thigh muscles, then you put these patches on their thighs, on their thigh muscles. And these patches should be just pretty close. The black and the white patches should be pretty close together. So just, like kind of position them about this close together on the same muscle. So then we can sit our patients in a sitting position so they can see the computer monitor. And what they're going to see is 2 channels on the monitor. So the top is their abdominal muscles. So these patches are on the abdominal muscles. So when they're not squeezing and they're not doing anything, the activity will be at 0 or just flat. Then this sensor is our anal canal sensor. So we're seeing some activity here, probably about 4 microvolts. So at rest, when the patient's not squeezing, we still see muscle activity because that muscle's constantly firing to keep the anal canal closed. So we are going to explain to our patients that, this is your anal canal muscles. When you squeeze, I want you to tighten your muscles around that tube in your bottom. And if you're using the right muscles, you're going to see the muscle activity rise. The higher it goes up means the more that muscle is firing, the stronger it's trying to squeeze, the more it's trying to squeeze. I don't want you to use your abdominal muscles. So this red line here should stay flat. So on this patient's first attempt to squeeze, they start to squeeze their abdominal muscles and now they're squeezing their external anal sphincter. So I would have my patient relax. And then what we do is we give them some feedback. We tell them, you used the right muscles, see how it contracted, but you are also using your abdominal muscles. So next time you squeeze, I don't want you to use any other muscles, only your anal canal muscles. So keep this red line flat. I don't want you to tighten up your muscles in your belly at all. And I want you to squeeze just around your anal canal. And then the other thing that I tell them that there's some good things going on with this squeeze. Try to give them positive feedback as well. So you tell them that immediately you recruited that muscle. Do you see how fast this upslope is? That means boom, she squeezed and the muscle just contracted really quickly. Some people you'll see a very, very kind of gradual rise. So we like to see this abrupt, contraction of the muscle, just really, really fast. The patient also met our goal. We'll put a threshold, this purple line here. That's our goal. So a normal squeeze should be 10 microvolts, and they should hold that for at least 10 seconds when we do these squeezing exercises. So she met the goal, but she immediately fatigued. So our goal with her is to get the muscle to be able to maintain that squeeze longer. So as you're doing this training, always try to give your patients some positive reinforcement, like, yep, initially you squeeze really good, but we're just going to work on trying to get that muscle to continue to hold that squeeze longer. So then what we tell our patients is, so next time you squeeze, keep your belly muscles really relaxed, and they can watch the monitor, but probably another more beneficial way is just have them put their hand on their belly, on their abdomen. If they feel their muscles contract underneath their hand, that means they're using those muscles. Sometimes it's easier for them to feel with their hand than try to focus on the screen, because they're also focusing on this bottom channel. I don't want to make it too hard for them. So next time you squeeze, you're going to keep your belly muscles nice and relaxed, flabby. And now you're only going to squeeze, tighten those muscles right around that tube, wrap those muscles around the tube. And this is the hard part, trying to figure out words and direction to get your patients to squeeze the right muscle. It's really, really hard. And when I first started doing this, I read probably 100 biofeedback articles. Nobody said what words to use. And I found out later, it's probably because it's really up to your patient it's trial and error. They try different ways to squeeze that muscle down there to get a response on the screen. So it's really more your patients to try to figure out what to do to produce this squeeze than you trying to teach them what to do. It's trial and error on your patient's part. So the next, so on the next squeeze, So this patient here, they're barely using their abdominal muscles. So I would give them really good feedback here. I'd say, great, you're not using your belly muscles, perfect. And then now the patient's squeezing. They're able to meet that threshold and they're able to hold it now for the 10 seconds. So, so this is the response that we kind of want. So the patient's going to do they're going to do multiple squeezes until they get it right, that they're able to not recruit their abdominal muscles. They're able to identify which muscle they need to contract. And they may not meet the threshold. They might not be able to get to my threshold that I set for the patient. And they may not be able to hold it that long, but as long as they're able to recruit the right muscle, not use their abdominal muscles, they're doing the exercises appropriately. So then they practice on their own without me coaching, without them looking at the monitor. Squeeze, hold it for as long as they can, relax for 10 seconds, squeeze. So maybe your patient can only hold that squeeze for 3 seconds. So at home, they're going to squeeze and hold it for 3 or 4 seconds, rest for 10 seconds, squeeze for 3 seconds, rest for 10. So, and they're going to do that 10 times in a row, 5 times a day. And they're going to do some sitting, some standing, and some laying down. So all different positions, and 5 times a day. So it only takes about 15 minutes, 20 minutes at the tops to do these exercises. And they just have to make it part of their routine. So when they go to bed at night and they're laying down, do 10 squeezes. While they're watching the news on TV and sitting, do 10 squeezes. While they're standing, doing dishes, do 10 squeezes. Find 5 good times during the day to do these exercises. Make it kind of a routine. So with that first session, we're going to teach them how to perform the exercises. We're going to get them to appreciate too, when they squeeze, you're going to ask them, can you feel that muscle tightening up? When you see this activity rise, can you feel that muscle tightening? Hopefully they say yes. So you say, okay, good. That means, that's what you need. That's what it needs to feel like when you go home. When you squeeze, that's what it should feel like. Some of your patients, unfortunately, don't even feel their squeeze. But encourage them that as that muscle gets stronger, there's a good chance as it gets stronger, they're going to be able to feel that difference in activity. So we're going to get them to kind of recognize what it feels like to tighten up that muscle. They're going to do these squeezes 5 times a day. We're also going to have our patients keep those diaries. So we have something to work on to see if there's improvement from week to week. We're going to set up a subsequent visit appointment. We may need to modify their diet. You may need to do other treatments with these patients. So it's not just biofeedback alone, it's diet. Maybe they're lactose intolerant, maybe they need more fiber in their diet. Maybe they need medications like Imodium, which is a very safe drug for your patients to slow down that stool so they can at least go out in public. So, if your patient needs to go on a trip somewhere and they need to go on an airplane, they're so afraid that they're going to have incontinence. So encourage them to take Imodium before they have an important event where they're afraid that they may leak. So let's see. So medications. Bulk up their stools. There's so many other things that these patients need to do in addition to biofeedback to help them get better. There are tapes available, and I think that there's some on YouTube to explaining these exercises. They're called Kegel exercises. So there's they can find some tapes. They can go on YouTube and find some more supplemental instructions for them. We have written instructions for our patients as well. So then a week later, your patient's going to come back. You're going to review their diary. You're going to see if there's any improvement with their amount of leakage, with their quality of life. You're going to make sure that they're compliant with the exercises. Then we're going to insert the catheter or our EMG sensor and our patches on the abdomen. And we're going to ask our patients to perform the exercises like they were at home. So they're going to be in a sitting position. It's nice to have their feet flat on the ground. And it's better to sit in a chair that's kind of stiff. They're going to feel their pelvic muscles better if they're in a stiff chair than a big fluffy couch or chair. So, so then they're going to be sitting. We're going to ask them to do their exercises exactly like they did them at home. And we're going to make sure that they're doing the exercises correctly, that they're holding for the amount of time we instructed, and that they rest for that full count of 10 seconds. Your patients want to rush through the exercises, and a lot of times they will not give the muscle that 10-second rest. Very important that they rest between each squeeze so they can produce another squeeze. So what we're going to reinforce with them, what they're doing right, what they're doing wrong. We're going, if there's any improvement at all, even if it's this much improvement, we're going to give them some positive reinforcement. It's a little bit better. This is really significant. Always give them motivation to continue the program. Okay, so that's kind of the protocol with the incontinence. And if we have time later, I'll actually get into the program and I will show you the program. So our other potential biofeedback is our patients. Or before we move, I'll tell you what, before we move on, any questions yet with the sensory, I'm sorry, with the strengthening biofeedback? Any questions yet?
Excuse me, can I ask a question about the normal values? It is not available in the books and the literature. Can we know what do you decide to follow? Which normal values about the resting, the squeeze?
Right. So so as far as when we do the EMG biofeedback and the EMG evaluation, there was I'm using values from Thomas Abel's lab. He's kind of a gastroenterologist, physiologist that's pretty well known in the States. I'm using their values, and they say that resting EMG activity is usually like around 3 or 4 milliamps. When they squeeze, they should generate at least a 10 milliamp squeeze, and they should hold it for 10 seconds. As far as manometry, like you were saying, it's hard to get some really standard values. There's a new classification called the London classification that came out maybe about a year ago, 2 years ago. So you can look up the London protocol and find out what the manometry normal values are. But just kind of a rough value is resting manometry pressures, anal canal resting pressure should be about 50 to 120 millimeters of mercury. And the squeeze should be greater than 100 millimeters of mercury with the manometry. But something to keep in mind, and I think that this is why we don't have a whole bunch of normals in the literature, is because it's all multifactorial. It's not just one thing that causes their fecal incontinence. It might not be just a low resting pressure. It might be that they have poor rectal sensation. They may have asymmetry. One quadrant might be weaker than another. They may have loose stools. They may have a weak squeeze. So it's a whole bunch of stuff together. And, 50 millimeters of mercury might be normal for one person, but it might be abnormal for another with really loose stools. So I think that's one reason why it's just been really hard to get normal values.
Thank you so much. What about the devices? We are discussing the device that's available by this company. What about the device with the balloon, the device with the water perfusion? Can we notice the difference? Why our device is better? Maybe is it better? Is it used for certain indication?
Right. Yeah. So I think when we do strengthening exercises, or when we do, and I'll talk about this a little bit later, but our exercises with our patients with dyssynergia, the anismus, the paradoxical push, I think the best device is something where you can use an EMG sensor like this, because this is easily inserted into the patients. They can be in a sitting position so they can see the screen. They can have their feet on the floor. They can assume a defecation position with the pushing. And this is very well tolerated. And then the fact too that we have our second channel with our EMG sensors, so we can look at ancillary muscles to see if they're pushing and squeezing appropriately and using or not using their ancillary muscles appropriately. So I think definitely for your dyssynergia patients, your paradoxical pushing patients, a device that has an EMG sensor is optimal. Your patients with sensory biofeedback, you almost have to use manometry because you need a balloon to inflate into the rectum. If you're just doing strengthening exercises, the manometry catheter is very nice as well. But I really like this because with manometry, your patients have to be in a recumbent, they're laying down on their side. So it's harder for them to see the screen. It's harder for them to recruit those muscles when they're laying down versus sitting. So I think for most biofeedback, the EMG sensor is better. But you can definitely use manometry as well. So if you don't have the EMG device, but you have manometry, you can definitely do training with manometry, and I can show you that as well. They're definitely both just really efficient. But with sensory training, which we're going to talk about next, you almost have to use manometry because you need that rectal stimulation balloon and a pressure sensor.
Thank you so much. What about the electrodes, the ground one? I'm not sure whether you tell us where should we put it.
The ground, okay. So if probably on the patient's hip. So if you're placing two patches on the abdomen, so the white and the black will be kind of maybe on the side of the abdomen, on the same side. Doesn't matter if it's the right or the left side. Then on the same side, the green electrode should be probably on the hip. Yeah.
Thank you so much.
You're welcome. Okay. Okay, so let's move on to the sensory training. So when you do a manometry study and you inflate the balloon in the rectum, if your patients cannot feel small volumes of rectal distension, so probably anything greater than 20 millimeters of mercury, 20 milliliters of inflation, then they would be candidates for sensory biofeedback. But they also have to feel at least 40. If they don't feel anything greater than 40, then they would not be candidates. There's probably enough neuropathy or neural damage that they're not going to benefit from biofeedback. So they have to feel at least 40 milliliters of rectal distension. So our goal here is to improve their rectal sensation, kind of retrain them to know what it feels like to have rectal filling, just retrain that brain. And we're also going to improve their pelvic muscle awareness by having them recruit and squeeze their external anal sphincter every time they feel that rectal distension. And this is the biofeedback I like because we see improvement a lot faster than the other biofeedback trainings that we do, the muscle strengthening or the pushing exercises. So with the rectal sensory, so we determined when we did the manometry that they don't feel small volumes of rectal distension and they're not squeezing their external anal sphincter when they feel that rectal distension. So that's almost a reflex. There's, a person kind of feels rectal filling and just subconsciously they contract their external anal sphincter just momentarily. So it's kind of a reflex, and that's kind of gone on these patients because they don't feel anything. So we're going to kind of get that coordination back. Okay. So our first session, so when we did manometry, we saw that they did not feel the rectal balloon distension and that they were not contracting their external anal sphincter. So we're going to come back on those patients, and our first session is going to be pelvic muscle strengthening exercises. So just like we discussed before, that's all we're going to do. We're going to teach them how to squeeze that muscle, not use their abdominal muscles, and they're going to go home and do these exercises for about a week or two. We're going to schedule another appointment for them to come back. And the reason too that we're doing these strengthening exercises with these patients is because ultimately they're going to be squeezing their external anal sphincter muscle when they feel rectal distension. So they have to learn to identify that muscle. And also, most of those patients also have a weak resting pressure as well. So we're accomplishing two things with these patients. So when we do our strengthening exercises with these patients, we're going to, kind of coach them to recognize their pelvic muscles when they squeeze. So this patient here, they're squeezing, but it's taking a long time for that muscle activity to really increase. We're going to try to teach them, next time you squeeze, just quicker, try to squeeze that muscle a little quicker. And I want a more rapid recruitment, something that looks more like this on the right. So we're with our teaching, again, we're just going to get them to not use their abdominal muscles when they squeeze, to produce a quick recruitment. We're going to get them to appreciate what it feels like to squeeze. Like when you see this activity go up, what does it feel like down there? Just pay attention to what it feels like down there. Also, sometimes pay attention to what it feels like when that muscle lets go, when you relax. What does it feel like when you release that muscle? So we're going to improve a pelvic awareness down there. So we're going to teach them just like we did with our pelvic strengthening exercises, that they're going to hold it at home. They're going to rest for 10, squeeze for probably 10 seconds, rest for 10, squeeze for 10, rest for 10. So they're going to do those exercises at home for a couple of weeks. Then they're going to come back for their second session. On their second session, we're going to have to use our manometry catheter because it has a rectal stimulation balloon on it. And on your, if you're currently doing manometry, your catheter may be the high resolution where you have lots and lots of sensors. That's great. If you're using a catheter with 4 sensors, you're going to turn off 3 of those sensors and only look at 1. You don't want your patients to have so many sensors to look at. So we turn on the rectal stimulation balloon, and we turn off, we keep the posterior channel on and turn off left, anterior, and right, if you have that 4-channel disposable catheter. Okay, so we're going to put that catheter in our patients. We're going to have this rectal stimulation balloon in the rectum. We're going to have our patients squeeze like they're doing the exercises at home, because again, we want to make sure that they were doing those exercises correctly. So with our first session, you were doing EMG, now you're doing pressure, but the technique should be the same. They should not be using their abdominal muscles. They should be holding the squeeze for the amount of time you ask them to, and they should be resting for a count of 10. So just make sure they're doing the exercises correctly. Then what we're going to do, and the problem with this catheter is your patients are laying down. So position your patients so they can see the monitor. And what we're going to do is we're going to inflate the balloon to a volume that they can feel. So if you inflated the balloon to 40, they felt that, then we're going to go down to 35. If they felt 35, then we're going to go down to 30. So we'll go to a volume that they can't basically feel. So, or you also know what from your manometry study, usually prior to what volume that they could feel. So we usually start with that volume, and then we just start going down and decreasing volumes of 5. So if they felt, let's say 35, we would inflate the balloon to 35 milliliters and say, okay, just pay attention in your rectal area where you feel that filling. So we put the air in and we take it back out. Within a couple seconds, we take it back out. So they get really used to what it feels like. Then we'll do, and at the same time that they feel it, we're going to ask them to squeeze their external anal sphincter. So here the balloon, they didn't feel it at 30, but let's say this was at 35 and they felt it. Then we would look down here on our channel. This is our posterior channel. We don't see a contraction here. So next time we inflate that balloon with the same volume, 35, we say, as soon as you feel that balloon, you need to just contract that. You're going to squeeze your anal canal and hold it for about 5 or 10 seconds, and then relax. Okay, so then we'll do a couple of these and make sure that they squeeze their external anal sphincter muscle at the same time. So this time the patient felt, this patient felt 30, but let's say they felt the 35, they squeezed their external anal sphincter, they held it. Oh, I'm sorry, this patient was bad. Let's see. Shouldn't have squeezed the time of the inflation. Okay, yeah, so this patient did not hold the squeeze. They did not squeeze at the inflation, but they squeezed it afterwards. So I'm going to have to instruct my patient now, as soon as you feel it, you need to squeeze that external anal sphincter. So now with reinforcement, I inflate the balloon, the patient squeezes appropriately. This is a little bit of relaxation from the internal anal sphincter relaxing. And then we tell our patients to relax. So when they've accomplished this about 5 times, where they feel the sensation, they contract their external anal sphincter appropriately, they hold it for about 5 or 10 seconds, then we're going to decrease it by 5 milliliters. So if they felt 35, then I'm going to go down to 30. And the chances are the patient's going to feel 30, even though they didn't the week prior to, because now they're really attuned to that area. If they didn't feel 30, then I might go up to 32. Okay. And then hopefully they would feel it. But when you inflate the balloon, inflate it very quickly. So you stretch the nerves quickly, like over a second. Put that 30 milliliters in and take it out after about 2 seconds. And so they'll accomplish this at 30 for about 5 times. Then you'll go down to 25 milliliters. And they should accomplish feeling it and contracting their external anal sphincter at the same time. So, and then we'll go down to 20. Chances are you're not going to get down that significantly on the first session. But if you get down to 5 or 6 or 7 milliliters in one session, that's really, really, really significant, or 10 milliliters. So if you started out at 35 and at the end of your session, they could feel 25, that's really, really, really good. So now you're going to send your patients home and you're going to tell them, whenever you pay attention throughout the day, if you feel something in your rectal area where you felt it during your session today, it's the real thing. Do something about it. Go to the bathroom or contract your external anal sphincter for a couple seconds to prevent that stool from coming down. So they have to kind of be aware of those sensations throughout the day. They're going to continue their strengthening exercises. So 5 times a day, they're going to do their strengthening exercises. In about a week, you need to get these patients back in. So these visits are a lot closer together. So when they come back the next week, you're going to use your manometry catheter again, and you're going to insert that catheter into the anal canal, and the balloon will be in the rectum. You're going to start out at the volume that they last felt. So if you got down to 25 on that patient, you're going to start out with 25 on this patient. Hopefully they'll feel 25 and they're going to contract their external anal sphincter at the same time. Sometimes on the first couple, they don't feel it. So they kind of regressed a little bit from your last volume. So you may need to go up to 35. They may feel 35 and they're going to contract their external anal sphincter at the same time. So repeat this several times, then go down 5 milliliters until they accomplish that 5 times, and then keep on going down. So, and it's really surprising. So many of your patients, after even 2 or 3 sessions, they're 100% better, and they don't come back for any more sessions. But encourage these patients to continue these pelvic strengthening exercises. Encourage your patients not to forget to pay attention to those sensations in their rectum. Do something about it if they feel rectal distension. And a lot of times these patients are going to have to come back in about 6 months for a refresher course. They regress a little bit. So you may have to, inflate the balloon in their rectum for a couple more sessions. Okay. Okay, so with these patients too, with the rectal sensation training, you're still going to do stool diaries with them. You're going to do the pelvic strengthening exercises with them. And one thing I didn't mention with our other patients, with the strengthening exercises, after about 4 or 5 months, if your patients are seeing improvement, then they can start tapering the exercises. So instead of doing the exercises 5 times a day, they can go down to 4 times a day for 2 months, and then 3 times a day for 2 months, and then twice a day for the rest of their life. You don't want them to lose these muscle fibers. So at least twice a day for the rest of their lives, they should be doing these Kegel pelvic strengthening exercises. So, on your patients with the rectal sensation, like I said, when they go home, they're going to be aware of rectal filling. They're going to squeeze when they feel that sensation. Keep up those stool diaries, because you're going to use that for feedback when they come back. from their session to session. They're going to come back sooner on your rectal sensation. When they come back, you're just going to assess their symptoms, make sure they're compliant with their exercises. You're going to have them squeeze like they're doing their exercises, make sure they're performing them right. And then we're just going to start decreasing those volumes. Okay, so in summary, and again, we're just talking about fecal incontinence here. We're going to figure out what's wrong with our patients, what mechanism is deficient to cause their fecal incontinence. And we usually find that out by either manometry or doing an EMG study. We're going to teach our patients exercises to get those muscles stronger. We're also going to teach them some lifestyle modifications. So sometimes, you know, like I said before, it's just not biofeedback that's going to get them better in the meantime, because it's a long process. In the meantime, we have to do other things, diet, medications, bowel habit training. So I'll teach them to wear clothing that they can get on and off quickly, you know, because when they have to go to the bathroom, they have to go to the bathroom quickly. So we want them to be able to get their pants off quickly. There's products, a lot of these patients who have fecal incontinence, they have skin breakdown. So we suggest products to protect their skin, you know, modify their diet. There's bowel habit training is really, really effective. And so we want their bowels to get into a habit of going to the bathroom at the same time every single day. If your patients with fecal incontinence go to the bathroom every morning and they totally evacuate, there's going to be less stool in their rectum to leak throughout the day. So bowel habit training is really, really effective. Fitness too, you know, if you're obese, you have more chance of fecal incontinence. People who smoke have more incontinence. So encourage, you know, physical fitness on your patients. And the other thing that's really, really, really important, oh shoot, is to give your patients emotional support. A lot of your patients don't get this emotional support at home. This is such a devastating condition. Your patients are devastated by it. Sometimes it will ruin a marriage. So, you know, give them some emotional support too, because sometimes they don't get it anywhere else, and tell them they're not alone. There's so many people with this same problem. They're not alone. Okay, so let's see. I think that's it. Oh, and I have instructions before I move on to, I have instructions that I'll show you a little bit later on this bowel habit training. But basically what the patients are going to do is every single day after a meal, about 20 minutes after breakfast. Breakfast is probably the best meal because, you know, your body's kind of relaxed already from being in bed, and you're not stressed out by the day and rushing around. So eat a fairly large breakfast. And if you eat a breakfast that's kind of high in fat content and a little bit of caffeine, so coffee or tea, something warm, that will start your gastric colic reflex. And about 20 minutes later, you may have the urge to go to the bathroom. So have your patients sit on the toilet for about 20 minutes. If they don't pass a bowel movement, they can apply a glycerin suppository to activate that bowel movement. Then the next day, the same routine, they'll eat breakfast. 20 minutes later, they'll sit on the toilet for about 15 minutes, try to pass a bowel movement. If they don't, they can do a glycerin suppository, which is very safe. And then hopefully they'll pass a bowel movement, and their rectal vault now is empty, and hopefully they're not going to leak for a long time. And they'll have complete bowel evacuation, so they're not going to have the oozing throughout the day. Next day, the same thing. After several days, their bowel is used to doing this, and they will not need the glycerin suppository, and they'll just spontaneously have a bowel movement. And then after a while, this just becomes a daily thing. This bowel habit training is good on your fecal incontinent patients and really good on your patients with the anismus as well. Get that bowel used to going to the bathroom the same time every single day. Okay, so before we move on to constipation, I want to, there it goes. Oh, I do have more. I thought I had more. Okay, yeah. Sorry.
Excuse me, Linda. I think there's two questions from Mohammed
there?
in the
Okay.
chat box as well.
Oh, okay.
So it would be
Good.
great if you can look at those as well. Thank you.
Yeah, I'll do that right now. Good, thanks. So let's see from the current slide. Okay. Okay, so the question was no improvement in a few sessions. When should we give up? So, I give it about 4 or 5 sessions before I give up. Yeah. So, and then after the 5th session, then I guess we have to figure out other ways to try to improve them. So again, diet, medications, yeah, and if it's just because your patients, your patients could be non-compliant. They might not be doing those exercises at home. So after about 4 months, 4 sessions, if there's no improvement, just really, really make sure your patients are doing the exercises. They can just tell you that they're doing them just to make you happy, and they really aren't. So make sure that they're doing the exercises. And then, yeah, after about 5 sessions, if they really are diligent about doing the exercises, then another kind of treatment is going to have to be determined. And there's probably, what drugs should be avoided before biofeedback? Probably, I don't think any. If your patients are on chronic pain medications for chronic pain, they're on those all the time. So there's probably no drugs that should be avoided. No, nothing about the drugs, I don't think. Yeah. Okay. Let's see.
Thank you.
Okay, you're welcome. Okay. So as I mentioned before, there's other things that you can do in conjunction with biofeedback, diet, medications, bowel habit training. A lot of these people need some psychological intervention. Their bowel condition has ruined their life. It rules them. And a lot of times there's a psychological component to, especially the constipation, dyssynergia patients. So psychological intervention kind of can be helpful. Why is my computer not moving? Let's see. Oh, let me try this. Okay. 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 So I'm not going to go into this, but biofeedback training in the United States, these are all published in the United States, but there is really, or some are from Italy, but there's really about a 70 to 90% success rate with biofeedback. So, it really, really can be. And sometimes you don't get total success, but if your patients see even moderate success, that's really, really significant. So, so definitely worthwhile to, give this a try. So, I have diagrams that I kind of show my patients. This one's a little complex for my patients, but sometimes I show my patients that this is the area we're working with. This is your rectum, so sometimes they need a little anatomy lecture. But I find that this one's helpful to show your patients that on your patients with the dyssynergia, the excessive straining, the inability to pass stool, that this puborectalis muscle is the bad boy here. He is causing this angle. And when they try to go to the bathroom, they squeeze this muscle and they make this angle more acute. So they're closing the door. So this diagram and then this one here is really good to show your patients that when you're at rest, we have this anal rectal angle that kind of helps prevent the stool from constantly leaking out. The stool has to make a turn here. When you don't want to go to the bathroom, you squeeze this muscle so the angle becomes more acute, harder for the stool to pass. When you want to have a bowel movement, you should relax this puborectalis muscle so the stool now has a straight shot to come down. So I use sometimes these diagrams to kind of help educate them. Sometimes if you just tell them, this is what you're doing wrong, sometimes they can improve immediately without biofeedback, but that's rare. So this is the bowel habit training, you know, exercise that I just kind of told you about. So we have these as take home instructions for the patients. We have stool diaries. I just try to make the stool diaries as simple as possible. So to have them compliant with it. So just check every day, you know, number of bowel movements, how, you know, what was the consistency of it? When did the leakage occur? Just try to make your diary very, very simple. This Bristol stool scale, I'm sure you've seen all this. If they want to, they can just type it as a 1 or 2 or a 7, whatever it is, to make it easier for their stool on their stool diary to complete that. And I also have a diet, diary, sorry. So again, make this kind of simple, but I don't have them fill this out every single week. I do a baseline, and then maybe a month later or 2 months later, I have them repeat the diary, the diet diary. That's a hard one to spit out. You know, I have the pelvic strengthening exercises, take home instructions for the patients. If you guys need these examples, I can send them to you. And then the quality of life that I do, it's just very, 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 very simple, because I want my patients to be compliant. I don't want to make things difficult for them. So just on a scale of 1 to 10, how hard is it to do your work duties, your daily activities, your social activities, the number of spontaneous activities that you performed in the past 7 days. Your patients with fecal incontinence, they don't do anything spur of the moment. You know, their incontinence rules them. So I like to know if they're able to just now, without even thinking, just do an activity. So I evaluate this from session to session to session as well, just to help me determine if their life is getting any better. Okay. So I'm going to just get out of here real quick. And I just want to, while we're talking about manometry or the manometry biofeedback, I just want to show you kind of a nice feature. So let me close out of here. My computer's acting up here. Sorry, there it goes. Okay. So if you have the high resolution manometry catheter, it can be very effective for biofeedback training. So I'm just going to bring up a patient. Okay. Are all of you familiar with the anorectal high resolution manometry? Okay. So I'm going to magnify the squeeze here. Okay, so if we were doing the biofeedback training, strengthening exercises with the high resolution manometry catheter, and we were not using the EMG sensor, this is really effective as well. So, and it's nice, the patients can really see these colors. So it can be very, very beneficial and effective. So I would explain to my patients that this is your anal canal resting pressure. You know, you're not using the muscle right now. It's just nicely closed. When you squeeze, I want to see those colors get redder and more orangey, redder and redder. So the redder the color, the stronger it is. So they can really kind of see that they're squeezing very well. The top channel up here where it's kind of a light blue, those are the abdominal muscle, the interrectal pressure. So I can see whether or not they're using their belly muscles by looking at the color here. So if this turned a little pale yellow, that would mean that they were using their abdominal muscles. So I would encourage them not to use their abdominal muscles. And a really nice feature is something called sync view. There's an icon here that looks like purple and pink. If I click on that, that's going to give me, oh, what happened to my thing? That's going to give me, a two-dimensional look at the sphincter. So at the very, very bottom, that's a sensor outside the body. So we don't have very much pressure. In the middle, this little narrow area, that's our anal canal. And everything above it is the rectum. It almost looks like an hourglass. So the tight area in the middle is the sphincter. So if I click the go button here, and you can do this in real time. So if the catheter was in the patient, they could see this in real time. So here, this is just, where's my cursor? Okay, it's really far away. Hold on a minute. Let me just start it here. Okay, so this is resting. Now squeeze, 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 squeeze. So you see how that tightens up there? So the patient, so you can say, yeah, you squeezed it beautifully. It should get nice and narrow there, and it should get nice and red. You can also rotate the axis, and now you're looking straight down the anal canal. So now this is at rest. Now squeeze, squeeze, squeeze until this turns really red in the middle. Just keep holding it, and now relax. So this is a really effective visually way of doing the biofeedback. And then the nice thing about the pressure sensor as well is when you do your sensory biofeedback. So let me just turn this off for 1 minute. Let me just get to the sensory biofeedback part. Okay, so let's see, positive sensation. Okay, so with the sensory biofeedback, again, you can inflate the balloon. So you'll know where you're inflating the balloon because you see increased colors in your rectal stimulation balloon. We see when you inflate the balloon, we see our internal anal sphincter relax. It's a little bit harder to see in the color, but it's turned a little bit red here. So the patient is squeezing their external anal sphincter, but I would encourage them to squeeze just a little bit tighter. And we would see, so as soon as you feel that rectal distension start to squeeze, and I should see some more orange right here, but I could turn on my sync view here as well. And let me start my measurement over here. Oh, my computer moved over here, sorry. Okay, so we'll start right there. We'll go. Okay, so this is at rest. Okay, we're going to inflate the balloon. So we're probably going to see some pressure up on our top channel here. Yep. And then what the patient should do, and I'm not sure if you caught it, but this is harder to do the sensory biofeedback with this, but they should be tightening this muscle a little bit as soon as they feel that rectal distension. So it should turn a little bit redder here. So the question before was, when to use manometry or the EMG. The manometry is really is effective for your teaching, especially if you have this high resolution catheter. Okay, but I like the EMG just because the patients can be sitting on it, on the catheter. They can be in a sitting position. It's easier for them to see the screen. Okay, and then the protocol. Let me get out of here. So the protocol with our EMG sensors, I can just kind of show you that. Let's see, Santel applications. Okay, so we have Diversitech has a biofeedback protocol. So we click on biofeedback. This is an EMG protocol. So we'll go into procedure. There's a constipation protocol. There's also a I think a strengthening exercise, but I always use the EMG constipation for all my training. So I will click on OK. And to calibrate, it's just really easy to calibrate. We have 2 channels. So I'm going to start EMG calibration. And on our box, there's a high and a low. The computer wants to know a low value, which is 0 microvolts. I click OK. And now it's going to ask me for a high value, which is 200 microvolts. So I click on high, I hit OK. And now my computer's asking me to verify my calibration value. So I'm on high, I'm going to click on low, and they should all go down to 0 microvolts. So calibration is really easy. I'm going to save it. I'm going to start a new patient. Okay. All right. And so the computer is going to tell you basically step by step on the left what to do. And these instructions are nice, but you kind of modify it for your patient. You know, you have to kind of, your patient's going to kind of dictate your instructions, but this will be a little bit to guide you. So you basically insert your catheter into the anal canal. So the arrow is pointing posteriorly. Oh, where's the arrow? Oh, it's right here. So the arrow is pointing posteriorly, and it's really hard to, this is an open circuit, so I really can't show you any numbers right now, but let me get this over here. But you're going to get, and then you're going to sit, you're going to put your electrodes either on your abdominal area or on the glutes, wherever the patient's using the muscles inappropriately. And you're going to sit your patients up, let them see the computer. And then you're going to tell the patients, okay, what I'm seeing on the bottom channel here, this pink channel, is your anal canal. And I see some numbers here. It's not it's at rest, but those numbers are not zero because your muscle's always firing to keep that muscle closed. What I want you to do next is, well, first of all, the computer wants you to do a resting measurement. It wants to know what the anal canal resting measurement or activity is. So we're going to click on our box to start our measurement. We're going to take about a 10-second measurement. There's a counter on the bottom right-hand side. After 10 seconds, it turns green. I'm going to accept this measurement. So now we're going to start our squeezing exercises. And the computer here does tell you this should be tailored to meet your patient's needs, but it's kind of telling you step by step what to do. So we're going to hit the greater than symbol to move on. So what we're going to do is ask our patients to squeeze and hold it for about 5 seconds. I try to have my patients hold it for 10 seconds because that's our ultimate goal. So I'll start my measurement and I'll tell my patients, now squeeze, tighten that muscle around your anal canal. And what I should see is this pink line going up. And I'll say, great, you're using the right muscle. And I'll accept my measurement after 5 seconds. And then I'll also look at their abdominal area. So hopefully the activity did not go up in their anal canal, on their abdominal sensors. So then I would just pause. I would freeze my screen. On the bottom, we have a freeze menu. And I would show my patients what they did. I say, okay, you know, you used your abdominal muscles. Next time, keep your belly really, really relaxed. But you did a good job squeezing. You know, I hopefully would have seen the activity go up. So I would say, you know, you squeeze great, you know, you squeezed here, you used the right muscles. But next time, keep your belly really, really, really relaxed. I just want you to isolate these muscles. So then I would do another squeeze, and I don't take measurements with every single squeeze, just a couple, so I have a record. So then I would tell my patients, okay, keep your belly muscles, wrap those muscles around your anal canal. Great, great, great. See that line going up? You're using the right muscles. Hold it, hold it, hold it, hold it. Now relax. And I would accept my measurement if I did a measurement. So then, and then sometimes I would freeze again and say, you know, when you squeeze, did you feel that muscle tightening up? And hopefully they said yes. He said, okay, that's a good thing. That's what it should feel like at home when you squeeze. And then, so we'll just do a whole bunch of these squeezes, you know, prompting them to squeeze correctly. And then the other thing that we can do is if our patients squeezed, our resting here is 10, so they should be able to generate another 10 milliamps of activity. So I could set a threshold. So we have a threshold on the lower left-hand side. I want her to produce at least a 10 milliamp squeeze. So I want 10 over baseline. So that'll be 20. So now I drew a line, and this is the patient's goal. So next time they squeeze, I want them to touch this pink line and hover there for the whole 10 seconds and then relax. So that's our ultimate goal. But if your patient could only generate a 5 milliamp, milliamp squeeze, I would make it I would just go a little bit above 5, so 6 here. I don't want to discourage them by trying to meet this goal that they're nowhere close to. So set the threshold just a little higher than what they're doing, so they can just kind of meet their goal just a little bit more. So you're just basically going to be just teaching them how to do your Kegel exercises by trial and error here, getting your patients to, getting into the pattern, squeeze, hold it for 10, make sure they rest for a count of 10, squeeze for 10, rest for 10, and just do measurements as you go along. Okay. So that's the fecal incontinence in a nutshell. Any questions right now? Okay, so let's see. Let me quit out of here. Oh, and then you can also I don't have it on here, but at the end of your study, wherever you took measurements, the computer's going to generate a report telling you what the squeeze activity is, what the abdominal activity is, and then you can use those values from session to session to see if there's improvement. Okay, so now I'm going to move, if there's no more questions about the incontinence, I'm going to move to constipation. Is everybody okay with that? Okay, so let's go to the constipation. Okay. Okay, so the other type of patient that can benefit from biofeedback is your patients with the pelvic floor outlet obstruction. So lots of terminology for this: paradoxical, push, anismus, dysynergia, outlet obstruction. You're going to hear a lot of terminology for that. But basically, these are the patients when you ask them to bear down, instead of relaxing their pelvic floor muscles, they're squeezing them. So it's a paradoxical response. And it's the puborectalis muscle and probably the external anal sphincter muscle that's contracting when they're pushing. They should be relaxing those muscles. So this is like a functional disorder. They weren't born this way. This is something over the years or months that they kind of started doing. And there's I think my next slide's about that. Oh, let me back up. But so these patients usually kind of present with chronic pushing, to defecate. They could spend 45 minutes on that toilet just pushing. They may have a sensation of incomplete evacuation, or sometimes nothing comes out. So usually these patients are very, very constipated, and they're going to get all those symptoms of constipation: the bloating, the distension, uncomfortable, lack of appetite, it's pretty, bad. Sometimes they have to do digital manipulation through the rectum or the vagina to help pass that stool. When you do a manometry study on these patients, or an EMG study on these patients, instead of relaxing that muscle when they push, they contract it. They're basically squeezing. So on manometry, when we ask our patients to push, on a normal push, you should increase interrectal push pressure. So you're pushing from above to push that stool down. So the normal response is we have increased interrectal pressure on our proximal channel, which is our balloon channel. I'm sorry, let me go to the right. I'm sorry, to the right, normal. You should be pushing from above. So we should have increased interrectal pressure, but the puborectalis muscle and the external anal sphincter should relax to allow that stool to come down. So when they're pushing, the puborectalis muscle lengthens, and our rectal anal canal opens up. That angle opens up. So these patients with the paradoxical push, most of them will push correctly from above, but instead of relaxing that puborectalis muscle, they squeeze it. It shortens, and it makes this angle more acute. So now the stool has this big turn to make and a closed sphincter here. So they're basically causing an obstruction. So we need to teach these people not to squeeze, to relax that muscle. So as I started to say before, this is a behavioral disorder with a lot of psychological aspects to it. So they weren't born this way. For whatever reason, they started doing the squeezing instead of relaxing. And it could be because they associate pain to that area. So if they have hemorrhoids or an anal fissure, if they had sexual trauma or abuse to that area, or some kind of a traumatic event, when it's time to go to the bathroom, they say, oh my gosh, this is going to hurt. So instead of relaxing, they kind of tense up. Hard bowel movements, the same thing. It's like, oh, they're painful and they have to push, push, push. So they, after a while, they just start to squeeze. It's really, really prevalent too in kids who retain children, 4, 5, 6-year-olds who start retaining their stool. They for whatever reason, they don't want to go to the bathroom because they're too busy playing outside or playing on their Game Boy, or there's some psychological thing going on. They're retaining stool. So they get used to always squeezing that muscle when there's that urge to defecate, and they get into this bad habit of squeezing instead of relaxing those muscles. There's a question here. Let me answer that real quick. How can you tell if this pubic muscle spasm and not just, okay. So the question was, how can you tell if it's spasm, if it's puborectalis spasm and not just simply dyssynergia? So when you do your resting measurements, either with the EMG or with your manometry, just stay in that position for a long time and just evaluate resting activity and resting pressure. So once the patients get used to the catheter, so probably after about 3 minutes, your waveform should be very flat. It should be very, very quiet. If you see a whole bunch of up and down movement, that could be spasm. When you inflate the balloon in the rectum, when you do your rectal anal inhibitory response, or you do your sensory training, whenever you inflate that balloon in the rectum, you should not see a whole bunch of spontaneous activity. If you do, then maybe it is this puborectalis spasm, but normally you should have a nice flat tracing at rest. And even after a squeeze, when you tell your patients to relax after a squeeze, that baseline should go back to just flat. If you see just a whole bunch of spontaneous activity, I think that's your clue. Okay, so let's see. Okay, yeah, and that's another thing too. On your patients with irritable bowel syndrome, they don't like any kind of rectal distension. Everything's kind of a little bit irritated there too. A lot of times on your patients with irritable bowel syndrome, with your resting activity or your resting pressures, a lot of times you'll see a little bit of spontaneous activity, especially after your balloon inflations. You'll see a lot of kind of spasm-like activity, and it takes a little bit to have them settle down. Okay. Okay, so when you do a manometry study or an EMG study and you see this paradoxical response to pushing, then they're candidates for biofeedback. But again, it's not just biofeedback that's going to help these patients. It's a multidisciplinary approach. You probably need to get, a lot of times you need to get psychologists involved. You need to have a lot of cooperation from your physicians to make sure that they're on medicines to keep their bowels soft. It's really, really almost impossible to pass a really, really hard stool. So we need their bowels to be soft. We may need medications to, Metamucil or something just to really keep them soft. We need, you need complete patient cooperation with this. It's really, really, really hard to teach somebody to relax a muscle. It's easy to squeeze a muscle and contract a muscle, but to relax a muscle is very, very, very hard. So we need complete patient cooperation. They have to be 100% into it, but taking their medications, if there is a psych component to help get some psychological help, you really need them to be cooperative and do bowel habit training and everything. And you also need a motivated healthcare provider. This, the success rate with fecal incontinence, it's really high, 70 to 80% successful, a lot less successful with biofeedback with this dyssynergia, because it's so hard to get a patient to relax that muscle. These patients and the healthcare provider need constant encouragement to stay with this, be patient. Hopefully we can get you better. Okay, so let's see, what's this slide? I haven't seen this in a while. Let's see. Okay, so, as I mentioned before, the EMG, some people call it a plug, but this is really the best way to do biofeedback training on your patients with dyssynergia. They can be in a sitting position. They can assume a defecation position, a squatting position. So, and they can see the computer a lot better. So this is really the best method. You can do manometry, but it's, you know, your patients are pushing. Are they going to push the catheter out? Are you really seeing really good results? This is perfect. And I'm not sure you can see on here, but we have these sensors, these metal sensors. They're long, they're linear. So as the pelvic floor descends a little bit with a push, you're still going to be making contact with the anal canal. So this is really ideal. So we position our catheter. The patients assume or they're sitting on a chair or a commode, and they can assume a defecation position when they push. And our goal is to have our patients see their abnormal response, which is a squeeze instead of relaxing that muscle. So we're going to, you know, kind of have it with repeated attempts, get them not to squeeze when they push. Okay, so our first session is we're going to do a baseline. We're going to do our baseline information. We're going to have, hopefully you can get some of these diaries to your patients before their first session. So we're going to have them do like a week of stool and diet diaries. We're going. They probably our first session, or they probably had a manometry study. They may have had some demography studies. You know, we're just going to kind of look at all of our baseline information to find out what's defective. You know, why are they unable to pass stool? Why are they pushing excessively? Why are they, you know, having all these symptoms? So, and once we look at all this baseline information, we're going to do an anatomy and physiology lecture with education with our patients. We're going to tell them about that puborectalis muscle, that they're not relaxing it, that they need to relax it in order to go to the bathroom. We'll show them that what they're doing is squeezing instead. We're going to kind of do some relaxation techniques with our patients, you know, teach them to start relaxing all their muscles from head to toe. And including keeping their pelvic muscles as relaxed as possible. Then we're going to teach them pelvic awareness exercises. So their very first session is going to be the squeezing, the Kegel exercises. And we're not going to teach them pushing exercises the first session. And that's because we need to get our patients to be aware of these pelvic muscles that they ultimately have to relax. So the best way to teach them where those muscles are and what they feel like is by doing strengthening exercises. So we're going to do squeezing and then relaxing, squeezing and relaxing, so they understand where those muscles are that they have to ultimately relax, which sounds a little counterintuitive. I mean, it doesn't really make sense, but it's really the best way to teach. So our first session, after we kind of do the anatomy and teaching, and we figured out that they're squeezing instead of relaxing that muscle, we're going to put our catheter in, and we're going to show them that this is your resting activity. And in this case, it's nice and flat, no spontaneous activity. So now we just think it's dysfunction of they're just squeezing instead of no spasm involved. So now we're going to say, okay, now squeeze around that tube. Don't use any belly muscles. Just isolate where you feel those muscles, or where you feel that tube. Wrap those muscles around that tube and just hold it, hold it, hold it, hold it. And now relax. And now you're going to rest for a count of 10. You're going to squeeze, hold it for 10, rest for 10. And then after a couple squeezes, then we're going to get our patients to, we're going to have them recognize this muscle. So we're going to tell them, okay, now squeeze. Can you feel that muscle tightening? Do you feel some tightness there? And they'll probably say, yes, I feel it. And I say, good, that's what you should feel. What you're doing is you're closing that sphincter. You're squeezing it. You're closing it shut. Now hold that squeeze and now relax. Can you feel that muscle right here ungrip? Does it feel like it's releasing? And they should say, yeah. And I say, okay, good. Now that means that muscle is now, it's not tightly closed. It's just closed enough to prevent leakage. When you go to the bathroom, when you try to push, it shouldn't feel like this. It shouldn't feel like that muscle's tightening. it should feel like this, that it's releasing, it's ungripping. So when you do these exercises at home, I really want you to appreciate when you squeeze what it feels like. And most importantly, when you relax, I want you to appreciate that ungripping, that relaxation feeling. Because when you push, that's what it should feel like, that muscle's ungripping a little bit. And then relax. So they're going to go home and they're going to do these squeezing exercises maybe they don't have to do it 5 times a day, maybe 4 times a day, sitting, standing, laying down. And they're going to really appreciate this muscle by squeezing and relaxing it, squeezing and relaxing it. So basically the same thing as your strengthening exercises. They're going to go home, do those exercises 4 times a day, make sure that they rest for a count of 10 in between. Okay. So then they're going to go home when they're squeezing, really paying attention to that ungrip feeling. They're going to continue their stool diaries and their diet diaries maybe. And they're going to come back usually about a week later. And we're going to, also when they go home in between their first and second session, tell them to do their exercises. Do not ignore the signals to defecate. When they have that urge to go to the bathroom, they need to take advantage of it because the body's doing all the right things. They have an urge to go to the bathroom. It's easier to bear down when you have an urge. The internal anal sphincter is relaxing because there's something in the anal canal. So that's going to kind of, help them have a bowel movement. Do not suppress it because it's going to be hard for that urge to come back. Do bowel habit training with these patients. So have them, try to use the bathroom every single day, 15, 20 minutes after eating, sit on the toilet for 15 minutes, do the glycerin suppository, get their bowels used to going to the bathroom every single day. If the physicians have put them on medications to help soften their bowels or whatever, make sure that they take all their medicines. Maybe they're on Amitiza or some of those other Linzess or some of those other medicines, make sure that they take those. When they do try to go to the bathroom at home and they're pushing, it shouldn't feel like a squeeze. If it feels like a squeeze, they should just maybe immediately try to relax and then try to push again. Because if it feels like a squeeze, they're squeezing and they're just pushing against a closed door, and have them maintain their diaries. So then they're going to come back their second session. On their second session, we're going to have them, put the tube back in their bottom. We're going to have them do their squeezes like they were doing their exercises at home. We're just going to make sure that they were doing those exercises correctly. We're going to make sure that they really appreciate that feeling of relaxation. Ask them if any of those sensations of relaxation have changed, if they have a better appreciation of it after doing those exercises for a week. And then we're going to practice pushing. So, we've shown our patients those diagrams about what the muscle should look like when they relax. And we're going to also show them what a normal tracing looks like. So show them a tracing that when they push, they should push from above. So we should see increased activity in the proximal channel. And then we should see a drop in activity on their anal canal. So show them what a normal should look like. And sometimes too, when you show your patient what they did wrong, that while they were pushing, they were squeezing, they say, oh, wow, I never really realized that. Sometimes just that little bit of education helps them tremendously, not very often, but sometimes you get lucky and that's all it takes. And, you're golden, but sometimes you have to continue doing these pushing exercises. So with the pushing exercises, we're going to have our patients assume a defecation position. So kind of lean forward a little bit. We're going to ask our patients to, first of all, squeeze. So when they squeeze, we're going to say, okay, you feel that tightness? Now immediately relax. And I want you to push and continue that sensation of ungripping, of relaxation. Push, 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 push. And now relax. So this patient, so they squeezed and then they relax, because I want them to understand, first of all, which muscle we're working on. Now relax it and push with it. So this patient's pushing, 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 but they're still having a paradoxical response. So then I tell them, okay, I don't want this activity to go up. I want it to, and then we set our threshold to resting it should go below resting. So it's just multiple attempts here that they squeeze, and now they're pushing. So they're pushing from above. We should see increase intrarectal pressure. And now they're able to drop that pressure below baseline. So it's just practice and practice and practice. So squeeze. Okay, now just ungrip, push and ungrip, get it lower, lower, lower. So this is just all trial and error with your patients. You know, we can tell them, you know, you're doing it wrong. The pressure's going up, you know, not the pressure, the activity is going up. You know, as soon as you see that activity up, just go ahead and relax. I don't want you to keep pushing and squeezing, but it's just multiple attempts with your patients to manipulate their body to get this appropriate response. Probably 70% of the time, you're not going to get them to have success on their first, this is their second session, but you're not going to have success when you start these pushing exercises. So because you limit your sessions to about a half an hour, it's really hard work for your patients. They get fatigued. So, you know, send them back home, just continue doing their strengthening exercises, their bowel habit training, keep their bowels loose. Another thing you can try is a squatty potty. You know, in the US anyway, you know, with our toilets, they're not real conducive to the angle. So if you elevate the feet a little bit with our Western toilets, if you elevate the feet a little bit, it strengthens the anal rectal angle a little bit. But if your patients defecate in a squatting position, then that's helpful as well. But so just have them come back the third session, and hopefully on the third session, we can get them to decrease their paradoxical response. But even with the pushing, if you notice, like a lot of times when your patient pushes, they're squeezing so hard that the activity is way up here. It's like 25 milliamps. If they start pushing and it goes down to 10 milliamps, that's even improvement. So tell your patient, that's better. That's so much better. But let's just try to get a little bit lower, and hopefully we can get the activity to drop below baseline. Have them repeat this appropriate maneuver several times, like about 5 times. Then we're going to move to pushing without a squeeze prior to it. So we're going to ask our patients to push. So they're pushing appropriately. They're using intrarectal pressure. They're pushing activity. They're pushing from above, but they're not. But here they're not decreasing the anal canal activity. So then we try again. So push from above, bear down, put pressure above your, push against your stomach, and open up the door. Release that pressure in your anal canal. So now we see the activity drop, and we say, okay, that's exactly what I want it to look like. Now repeat that again, and repeat that again, repeat that again. Get them to do it about 5 or 6 times consecutively. So, and then you're going to have your patients come back in about another week, another session. Make sure that they just keep on doing this the right way. If they do, and they're having improvement in symptoms, that we don't see them anymore, but these patients will probably need a refresher course in about 6 months. They kind of go back to their old ways. So, and then after a couple sessions, I really don't have them do the strengthening exercises at home anymore, unless they have a weak sphincter. Some of your patients have a weak resting pressure and a weak squeeze because they have chronically pushed. They pushed, compressed the pudendal nerve, and as a result, they have muscle weakness from this excessive chronic pushing. So if you do see weak resting activity or resting pressures or squeezes, then continue the strengthening exercises for several months. Okay, and so just with this response got better and better with subsequent attempts. It's got lower and lower and lower, but you have to be patient. It takes a long time for these patients to get better. It's a hard thing to teach them to relax that muscle. So just as I mentioned before, a lot of other measures have to be done in addition to the biofeedback. Okay, and then bowel training is really, really good with these patients to do the bowel training. Get that bowel used to going to the bathroom every single time, every morning. Okay, so this is just that bowel training protocol I showed you before. So, you know, I don't, Wexner, Stephen, I think his name is, he's from out of Florida. He does a lot of pelvic muscle retraining, and they're just really diligent with it. They just, they just spend so much time with their patients, and they have a whole team working with these patients. They have a really, really good success rate, but I think the general population doesn't have this high success rate. But again, just work. It's a lot of work, but it can happen. Some people in Europe, they do it in the United States too, but it's more prevalent in Europe. I think they have more time, better reimbursement financially, but they actually do balloon inflation. So they'll inflate the balloon. Yeah, so they're using a manometry catheter. They'll inflate the balloon in the rectum, and then they'll tell their patients to push. So this is kind of a good thing, because it's really hard to bear down when you don't have an urge to go to the bathroom. So by inflating the balloon in their rectum, they have the urge to go to the bathroom. They bear down. Sometimes you'll have a little bit better success relaxing that muscle. Okay, and okay. Yeah, and we don't do this. I don't know too many people that do this, but some people too, they will actually inflate a balloon in the rectum, and then they will actually pull it out of the rectum to get that patient aware of the sensation of having a bowel movement, anal dilation and having a bowel movement. I wouldn't recommend this until your patients get some success with decreasing EMG activity with their pushes. Oh yeah, okay, so that's really about it. Okay, so, and then, you know, the biofeedback program, with computer's like kind of doesn't want to get out of here. There it goes. So the biofeedback program is with the EMG. It was similar to what I just showed you. You know, you're going to have your 2 channels, and you're just going to encourage your patients to set their threshold. So when they bear down, that the EMG activity goes below the threshold. So instead of setting your threshold high, you're going to set it low, below baseline. All right. So questions? Or do you want me to show you the, if you want me to go into the protocol, I can show you that protocol too, but it's basically what I showed you with the fecal incontinence, but I can show that to you if you wish. Dr. Abdullah, you're on mute, so I'm not sure if you have any questions or not for me. Yeah, I think everybody's on mute. So if you have a question, unmute yourself, or you can go into the chat.
Excuse me, I have a question.
There you go. Now I hear you. Good.
I want to clarify from you what is about the action of squeezing. It is we when instruct the patient to get a squeeze.
Yeah.
Is it the squeezing of external sphincter or the pelvic floor?
Yeah, the external. Yeah, so the external anal sphincter. So, so patients, you know, if you had your sensor in the anal canal and you asked your patients to bear down, to push, they're going to have a hard time figuring out which muscle do I need to relax. So initially we just tell them, okay, squeeze around your anal canal, like you were doing your exercises at home. So your external anal sphincter. So now they know which muscle they need to relax. So now you tell them to relax, and they feel this muscle relax, ungrip, and then you tell them, okay, you feel that muscle ungripping, push, and continue that sensation of this muscle relaxing. So by squeezing, you sort of fatigue the muscle too. So when you tell them to relax, now the external anal sphincter really relaxes, and they're pushing at the same time. So that squeeze 4, oh, go ahead.
So it is the training of external sphincter or the perfect floor, including the internal.
It's the external anal sphincter, and maybe, and probably a little puborectalis muscle as well. Because when you squeeze, the puborectalis muscle and the external anal sphincter, the levator anine muscles, you know, they all contract a little bit. So it's really the whole pelvic floor. But
so there's no training for internal sphincter.
no, the internal sphincter, it's all involuntary muscle. We have no control.
Yes, sure.
Yeah.
So
Yeah.
the main exercise is for external sphincter.
Right.
Puborectalis, maybe for puborectalis.
Exactly. Right.
So the second question, in the action of pushing, do you mean that the abdominal wall contraction, like an action of defecation?
The abdominal, yeah. So if I understood your question correctly, yeah. So they need to use their, basically, they have to kind of use their abdominal muscles. You're pushing from above to increase interrectal pressure. So they're kind of using their abdominal muscles. So so it's kind of so pushing against the diaphragm and increasing, yeah. So that pushes the stool down. So there's 3 different patterns, or 4 different patterns. So paradoxical pattern 1 is when they use their abdominal muscles appropriately, they push from above, they push against their belly muscles to push the stool down, but they have a paradoxical increased activity in their anal canal or their puborectalis muscles. So that's type 1. So they use their belly muscles appropriately, but they squeeze. Type 2, I believe it's type 2. I just have to look. Hold on one second. My cheat sheet. I usually see the paradoxical response. I always see is just type 1. The patients bear down appropriately from above, but they squeeze their puborectalis and their external anal sphincter muscle. So type 2 is they push from above appropriately. So they use their abdominal muscles, but there's absolutely no change on the external anal and puborectalis muscle. So they're not doing anything here. And then type 3 is they do not push from above, but they squeeze their anal canal and their puborectalis muscle. And then type 4 is there's no abdominal change in activity and no change on their anal canal activity. So they're not doing anything. It's just flat. So there's those 4 patterns.
My another question, you said that to ease the action or defecation or to relax the muscle, you instruct the patient to elevate his feet. By what mechanism? By relaxation of puborectalis?
Wait, I'm sorry. Can you repeat the question? I'm sorry.
You said that to ease the action of defecation or relaxation, we instruct the patient to elevate his feet.
To elevate his feet, they can. Yeah, so it's mostly like in the toilets in the Western areas. They're not real conducive to defecation. So yeah, so we just raise the feet like on a Western toilet, like about just their feet should be like about about this high. Like what is that? That's like about
to make the knee above the abdomen.
No, not above the let's see, not really above the abdomen. Let me think. Yeah, so the knees would be above the abdomen. Exactly. Knees would be above the belly button. Yeah, exactly. Yeah.
By what mechanism is easing the defecation? By relaxation of puborectalis during this maneuver?
So by elevating the feet, it changes the angle of the it just changes the angle of the puborectalis muscle. So now it's just a little bit straighter. It just it does. I don't think it changes. It doesn't change the length of the puborectalis muscle. It just somehow changes the angle. So it's just a straight shot now for that down. Yeah. And when they actually bear down and they decrease the activity, the puborectalis muscle actually lengthens. But I think by just raising the feet a little bit or being in a squatting position, that just changes the angle.
You said that to instruct the patient about relaxation. Relaxation is a passive maneuver, not an active maneuver. So how to
Right.
teach the patient to get relaxation?
Yeah, it's just, yeah, it's so hard. It's so hard to do this. So basically, if they bear down appropriately, so they push from above, and then they just visualize in their brain of not squeezing their anal canal. I mean, that's just the basic thing. Just don't tighten it up. Just push from above, and then just don't let that muscle tighten up. The muscle activity decreases. So it doesn't fire so much. So as long as they don't squeeze and they push from above, the muscle doesn't, quiets down. It doesn't fire so much. And then that causes that puborectalis muscle to lengthen and decrease the pressure there. Yeah. But then
Thank you very much.
Yeah, and the patient, it's so hard to explain. It's so hard to explain to a patient how to relax that muscle. But what you have to do is just tell them, it's when you push, it just should not feel like it's tightening up. It cannot squeeze. It should not feel like it's tightening up. And it's really trial and error on your patients to get that muscle not to squeeze when they push. And this is where I got so frustrated when I first started doing the pelvic muscle retraining biofeedback. In all the literature, it doesn't tell you what to tell your patients. And I never knew what to tell my patients to get them to relax that muscle or not to, to quiet it down. But so basically it was just like, if it feels like it's starting to tighten up at all, or if you see that line going up at all, just stop. And then just try to keep that muscle down there as loose as you can. And the other thing that I tell these patients is throughout the day, just think about your pelvic muscle, and it shouldn't feel like it's tight. A lot of people manifest their stress in their shoulders. Their shoulders are always tight, or they get headaches. Other people will manifest their stress in their pelvic area, and they'll always slightly contract that muscle a little bit. So on those patients with the levator ani syndrome or the proctalgia fugax, or some of these patients with the obstructive defecation, I'll tell them, like, throughout the day, just think about your pelvic floor and just consciously trying to keep that muscle relaxed. Ask yourself, am I squeezing it? Is it squeezed? And just like relax your shoulders or you relax your eyebrows, just try to keep that muscle as loose, as relaxed as you can throughout the day, and not because subconsciously, they may be sort of contracting that muscle. So with these patients, I kind of tell them throughout the day, just think about keeping all that pelvic area as just loose and relaxed as possible. I don't know if that helps or not, but it doesn't hurt.
Thank you very much.
You're welcome. Okay. And you get better at this. I felt so insecure with my first couple patients, and especially if they didn't get better, I felt so insecure and helpless. But you get more confidence, and you realize it's just really the patient has to do really most of the work. They have to manipulate that muscle, figure out which one to use to get it to relax and to squeeze, and they have to do all their exercises. They have to be diligent with their exercises and do them every day at home. And your job is to be a coach and say, yep, you did that right. No, you kind of went up too much. You're the coach and keeping them encouraged to stay in the program. And yeah. Okay. Anything else I can help you with this morning or this afternoon or this evening? It's probably this evening for you.
I have a question about the anorectal manometer in general.
Okay.
While we analyze the anorectal manometer, why we make all the values 0?
Why do we make what 0?
The values, you should make all the values on the baseline and make it 0. What's the benefit of that? Why we don't have such a thing in esophageal manometry, let's say?
Okay, so with anal manometry, you know, let me think. With anal rectal manometry, you know, usually you position your catheter in the rectum, so all your sensors are in the rectum, and then all your values are based on pressures greater than rectal pressure. So when we do the manometry study, it looks like all of our pressures start at 0 because we zero our channels. But the computer is really basing the 0 value at rectal pressure. So did that kind of answer your question? You know, the 0 on manometry is just our visual reference. So we have a visual reference as 0, and anything above that is going to be anal pressure, but 0 really is rectal baseline. So rectal baseline is rectal pressures are like 20, 30 something millimeters of mercury. So, and the computer knows that those rectal pressures are 20 or 30 millimeters of mercury, but we visualize it at 0. So we're really not starting at 0. We just look at it at 0.
I see. But the problem is the anal baseline, usually after a while, after a few minutes, it becomes less and less. Sometimes it's really disappear. So how can we know that the computer is assessing the squeeze and the relaxation relative to the first minute of the examination and not the real baseline, which is sometimes very weak?
Yeah.
Yeah,
I know. And, you know, there's different pressures throughout the rectum too. So as you pull out your catheter, do you have the high resolution manometry catheter? Is that the catheter you're using?
Yes.
Yeah. So when you put all 23 of those sensors inside the rectum, there's different pressures throughout the rectum, and you've got the valves of Houston. There might be a little bit of stool in the rectum pushing up against your sensors. And then as you start to pull out your catheter and you get into the anal canal, the pressures are all over the place sometimes. So what I do, and I'm not sure this is optimal, but I will pass my catheter so it's all sensors are in the rectum. I do my rectal baseline there, and I hope that everything's pretty stable. And then, what I do first is I do a baseline outside the body at atmospheric pressure. So all the pressures on all 23 sensors are the same at atmospheric pressure. Then I put my catheter into so all 23 sensors are in the rectum. So that second reference line, I do a rectal baseline measurement. I pull out my catheter, and if I see a lot of variability with my pressures, some dropped below 0, some are 20, some are 30, they're not all at 0, then I use my atmospheric baseline for my measurement, and I turn off, I delete my rectal baseline measurement. What I'm encouraging Diversitech to do, and I think they'll do this with the next software revision, is to only do one rectal baseline measurement. So the rectal baseline measurement will be in the balloon, and you won't have those 22 other sensors, and you're going to get a more stable baseline. Yeah, I get really frustrated with that because as I pass the catheter down, my pressures are all over the place. Yeah.
In the esophageal manometry device, they put the second resting measurement. I think it is wise to do that also on the anorectal manometry.
Yeah.
And in the report, we will get the resting pressure negative. So to be frank, we depend our own clinical judgment on whether it is high or low. Because if we depend on the device, all the measures will be in the negative.
Yeah, I agree 100% with you there. And, you know, this London classification or protocol, whatever, they're also suggesting that once you position your catheter in the anal canal, wait 3 whole minutes before you do your resting pressure, because that will allow the catheter to warm up and you don't have the drifting. And also the patient has accommodated the catheter. You don't have spontaneous activity. But I think you're right. I think at the end of the study, sure doesn't hurt to do a second anal rectal study too. The only problem at the end of the study is sometimes your patient, you've done the balloon inflations and the sphincter is kind of a little bit irritated from those balloon inflations, and you may have a little spontaneous, internal anal sphincter relaxation from those balloon inflations. So maybe at the end of the study, if you do one there, you might want to wait 3 minutes or so too, or a couple minutes to let everything quiet down after all those balloon inflations. Yeah.
Thank you so much.
Sure. Okay.
Excuse me, do we expect any newer software for the anorectal manometry anytime soon?
I'm not sure. That might be a question for Jonathan Moreno. He may have some insight on that. I'm not sure what the latest is. They just released 3.2, ZView 3.2, but that's for the esophageal. So I'm not sure what the plans are for the anal rectal. I know they're working on it, but I'm not sure the date. Yeah, but and when they do release it, it will probably follow. It will definitely follow that London classification protocol by waiting 3 minutes before you do your pressures and on and on. Yeah, yeah.
Can I ask about the rectal compliance, which is optional? First,
Right.
why it is optional? Do you recommend it? Do you do it in your daily practice? And how to do it? Because it's not that clear in the literature how to do it.
Right. So I do the rectal compliance on some of my patients. So my patients with the irritable bowel syndrome, I like to do it on them because what I suspect is that they kind of have a non-compliant rectum, or they have a very, kind of low threshold for, inflation. So, so kind of the protocol is that you, with 50 milliliter increments at a time. So you'll put 50 milliliters of air into the balloon, and you'll keep that air in. After 30 seconds, you're going to do an interrectal baseline measurement. And then you'll also ask your patients, can you feel that balloon? And chances are they don't, because their body's gotten used to this sensation. But you wait 30 seconds before you do an interrectal or interrectal pressure measurement to wait for the rectum to accommodate it. So then after a minute, you'll put in another 50. So now there's a volume of 100 milliliters in the balloon. The patients will probably say, well, I really feel that. But after 30 seconds, the rectum should open up, accommodate that volume. You'll take another interrectal baseline measurement, and the pressure between 50 and 100 should be almost the same. There should be the rectum should not be squeezing up against the balloon. Then, and the patient should be able to tolerate it after about 30 seconds of getting used to it. Then after a minute, you'll put in another 50 and then another 50 to a volume of 200. So after every inflation, you wait 30 seconds and do a measurement. And between 50, 100, 150, and 200, there should not be much of a change, meaning the rectum's very elasticy and it's accommodating that volume. So if you got to a volume of 150, and there was big changes between 50, 100, and 150, the pressure really increased, then maybe it's a kind of a little rigid or a non-compliant rectum, and the patients will probably tell you, I can't stand it. They should be able to get to a volume of 200 without a really urgent need to go to the bathroom. So, so I kind of use it on my patients with irritable bowel syndrome, and chances are I don't get past 100, and they just don't tolerate it. If my patients have any kind of inflammatory bowel disease, or I suspect radiation proctitis, or if they've had any radiation treatments, or if they have a colostomy, a diverting colostomy, I would never do a compliance, because I know they have a non-compliant friable rectum, so I don't do it. My patients sometimes with fecal incontinence, I'll do a compliance study, because I think that maybe they don't have a very compliant rectum. So their rectum's not accommodating the stool, and it has nowhere to go except out. So that might be contributing to their fecal incontinence. The London protocol, they took it out because I think that they felt, I haven't gotten a really good answer, but I think that they felt that it didn't give them that much added value or information, and they thought that it wasn't that accurate. They thought a Baristat, a balloon Baristat, was more accurate, but I mean, I don't even know, I'm not sure even if that's technologies readily available for people, or if there's any financial reimbursement either for that. But so yeah, they kind of took it out, but I haven't gotten a real concrete answer about why they thought it was kind of little invaluable, but I think that they just didn't think it was that accurate. But yeah, but the fact, when you do a slow sensation study and you find out first sensation, urge, maximum tolerated volume, I get a lot of sort of compliance information from that as well. If you could only inflate the balloon to, let's say 130, and they just have an urgent need to go to the bathroom, and they're very, very uncomfortable, that's giving me information about compliance as well. Yeah. Yeah, and I don't think it's real on my constipation patients, because sometimes they have a mega rectum. I don't see much value in them.
I see. Thank you. Can I have another question? Is there any time for it?
Oh, sure. Yeah, definitely.
We face a lot of patients with the suspicion of ultra short segment of Hirschsprung disease.
Oh.
And the problem is there is a mega rectum. And I'm not convinced that I by inflating my small balloon inside his mega rectum can get any benefit from that. Do you have any tricks for that?
Yeah. There's several. So if you do not see, when you inflate the balloon and you do not see, let me see, I wonder if I can get, let me get into a study. Okay. Okay. Okay, so when you inflate the balloon and you do not see a rare, so you don't see this nice kind of green coming down, the first thing I do is I look up in my rectal stimulation balloon channel and I make sure that I inflated the balloon. So you should see a color change here. So if I didn't, then I would make sure that my stopcock was in the right position, that I was really inflating the balloon. So that's troubleshooting number one. Okay, the other thing I do is I ask my patients if they felt it. So if they did not feel, so I see, yeah, the balloon inflated here, but if they didn't feel anything, then I would think, I wonder, especially if it was a large volume, let's say 30, 40, 50 milliliters of air, then I would wonder, I wonder if they have neuropathy and they just don't feel it, or do they have a megarectum? So if I inflated that balloon to 60, I see, and I don't see a rare, I know for sure I inflated the balloon, then I would wonder if it was a megarectum. So I would have to kind of, gauge their symptoms. So, if they have diabetes or whatever, then I would wonder about neuropathy. But another thing that can happen is then I would think about megarectum because I'm just not seeing anything. But then I would also, and if they didn't feel anything, and I didn't see a good rare, then I would think, maybe it's a megarectum. But the other thing that can happen too is watch your patients, because when you inflate that balloon, they usually feel it, and they can actually squeeze their puborectalis and their external anal sphincter muscles so tight that they can override rare. So watch your patients, and if it looks like they're really, really squeezing really, really tight, instruct your patient, say, I know you can feel that balloon. Try really hard not to squeeze. Just keep your bottom nice and relaxed. So sometimes they really can override it. So watch your patients. But also when I'm doing my slow sensation study, I can go I'll go all the way up to 200. So when you're doing your slow sensation study, you should be able to see the rare too. The internal anal sphincter should be relaxing while you're doing your sensation study. So you're all the way up to 200. So even with a megarectum, the patient should, I don't know, they should kind of feel something, or you should be able to stretch some nerves with a megarectum. Yeah. And that's tough, but kind of, 200. And, another thing you may want to do is just inflate that balloon just a little bit faster. Your syringes are only 60 milliliters, so you can only put 60 milliliters at a time, but maybe, put in, just a little faster and just see if you can get a rare response. But usually even at 200, I'll see something at 200 usually when I do my slow sensation study. It's definitely below resting. Yeah.
So why they put volume and not a pressure when we use rare or sensation? I think it's more logic to use pressure rather than volume, because it might not even touch the rectal mucosa.
I know I didn't catch your question. I'm sorry. Repeat.
Well, in the protocol, they use always put 60 millimeter, put 50 millimeter. Why they don't use pressure rather than volume? Because pressure is more accurate. If you have a child, it will touch the rectum earlier, and the pressure will rise. Well, in an elderly or patient with megarectum, they have larger rectums, and the pressure will not rise until we reach 200, 150. Why do they do volume rather than pressure? I think pressure is more logic.
Yeah, you know what? I don't. I don't have an answer for that. I'm sorry. Yeah, and I'm not sure if that's even addressed in the London protocol. Yeah, I don't. I haven't. I'm not sure. I don't have an answer for that. I'm sorry. Yeah. I'll see if I can find and I'll see if I can get an answer for you. But I'm not quite sure. Let me just write that down.
So, in your practice, where is the manometry in your constipation flowchart? Is it before endoscopy? Is it after? Is it before enema? After enema? Should you have at least an X-ray? What is your practice there?
Yeah, so almost all of our patients will have some kind of a workup before manometry. Manometry is usually like one of the last things. So so they usually have had a colonoscopy or a sigmoidoscopy, barium enema, defecography. They usually have had something before the manometry. They just really want to make sure that there's some obstructive lesion there or something going on. So yeah, and a lot of times we'll do the manometry before the defecography, but but usually they've had something done just to rule out any kind of inflammatory bowel disease or any kind of obstruction before we do the manometry. Same thing with esophageal manometry. Usually they've had an endoscopy before the esophageal manometries as well. And then as far as the enema, oh, it's across, it's kind of everywhere. Gosh, 30 years ago, Arnie Wald, he was kind of one of the big researchers with anal rectal manometry. He felt that no enemas because you before the procedures, because you want to measure the sphincter in its normal state. You don't want to irritate the rectum or change just the normal state of everything. But people kind of now adopted a protocol where they get 1 or 2 enemas about an hour and a half, before the procedure. So they'll do the enema at home and then they'll have their procedure. In my practice, we kind of look at our patients and we kind of decide from our patients. If our patients have just terrible, terrible fecal incontinence, we don't want to irritate everything by having them do an enema and then they leak all the way to the hospital for the procedure. So with our patients with really bad fecal incontinence, we do them unprepped. We just don't want to irritate everything. Our patients with constipation, really severe constipation, is kind of nice, I think, to have some enemas just to clean them out a little bit. I think we get a little bit better sensation study.
Thank you so much.
You're welcome.
Excuse me, do we have the time during this procedure to read to analyze a whole anorectal manometry session?
Sure. Okay, so let's just do this patient I have here. So and I'm going to kind of start with the waveforms, or with the waveforms too, with the editing. We'll just start from start to finish. Okay, so usually what I do is I turn on my analysis tool. And what I want to do when I review the study is I just really want to make sure that all my measurement boxes are in a good location. So this first measurement on the left, this is my rectal baseline. And I feel pretty comfortable that this is a very good measurement because all the colors are pretty consistent. So I'm going to be happy with that. And you know, your question about the baseline, if I turn off my color. Okay, I think they probably did this outside the body because you see how kind of flat it is. I think they did this outside the body, but you may want to look at your baseline measurement in line tracing to make sure that your lines are all pretty flat. But typically though, if you're in the rectum, these channels are all going to be kind of above the 0 reference because there is pressure in the rectum. I think they did this measurement outside the body. But if you did this inside the rectum and you saw pressures above the baseline, and they're not all going to be the same because there's different pressures throughout the rectum. But as long as they were all kind of pretty consistent, you don't zero, you don't visualize the pressures at 0. You just keep them right where they were. So like around 15 or 20 or 25 millimeters of mercury. You're just going to keep them all where the computer sees the rectal baselines, because any pressure greater than rectal pressure is your anal canal pressure. Okay, so let me get back to my 2-minute window. Okay, so then typically what you should do is you should pass your catheter, and you should so you visualize your anal canal. 1 centimeter should be outside the body. You should span the anal canal, and everything above that is in your rectum. Now you should probably wait 3 minutes before you do your resting measurement. And when you do your measurement, just make sure your box, when you edit, is in a nice quiet area. You want it all to be nice and consistent. And they also suggest that measurement now is 30 seconds long. So this one's probably 15 seconds, so I can make that measurement bigger if I wanted to. Okay, so then we're going to do a voluntary squeeze measurement. So just make sure that you started your measurement before you asked your patient to squeeze. The computer needs a little bit of information before, baseline information before, to calculate this accurately. So then we'll have them squeeze and hold it for about 5 seconds. And then we'll wait 30 seconds and we'll do a second squeeze. And then the computer will take the best of the 2 values. So, so if I looked at this in line tracing, in our conventional tracing, and I click on it, the computer, it's going to give you 2 values. So, and it's going to look at all pressures from 5 centimeters all the way down to the anal opening. And it's going to give you 4 values at each station: posterior, left, anterior, and right. So you can look at symmetry. So, and the computer is going to give you 2 values. So at 1 centimeter, the posterior, which is green, is our green line here. The maximum contraction is 209. So that's the total anal canal pressure. That's resting pressure plus all the added squeeze from the external anal sphincter and the puborectalis muscle. So that's total anal canal pressure, and that should be greater than 100 is normal. And then our squeeze, that's just external anal sphincter pressure. So that's totally external anal sphincter. And that should be kind of, so that should be double, it should be double resting. So this patient met that criteria. So just remember that the squeeze is external. So if you see very, very, very low numbers here, let's say 20, that means that there's external anal sphincter damage. And then the maximum contraction is external plus internal anal, total anal canal pressure. How much pressure can prevent the stool from leaking out? So the computer is.
Excuse me, can I ask about these X's, the X marks? It
Yeah.
represent the highest value. What about the vertical lines? What does it represent?
The vertical, let's see. So I'm not sure which vertical you're looking at, but so let's see. So we have our resting. So kind of, I'm going to look at this blue channel right here, which is left. So this blue channel right here, right where my arrow is, that's resting pressure. So that's the pressure before the patient squeezed. And then the line, the black line continues. That's just resting pressure right there. So then when the patient's squeezed, the patient's going to, or the computer's going to put an X at the highest squeeze pressure. So this X here is the maximum. So it's a maximum contraction. So that's all the resting plus the added squeeze, total anal canal pressure. And then the squeeze pressure is just everything from resting above it. So doesn't count resting anymore, just all the added pressure. So did that answer your question? Yeah, and whatever.
Yes, I will tell you when I saw the vertical lines, I will ask you about it. Thank you.
Okay, good. Okay, so so when you, we'll look at the report in a minute, but usually typically your highest pressures are going to be at 1 and 2 centimeters from the anal opening. So you'll also, and this is shown in the report better, but you can kind of look at symmetry too. All these pressures are similar, 230, 192, 221, 209. They're all pretty similar, but if you had a defect, let's say the anterior quadrant, which is red, you may see like weaker pressures there if the patient had a tear or something. So we do look at symmetry as well. If you're looking at color, it's hard to see the symmetry, but they've superimposed all of our lines here. So if you have a symmetrical sphincter, all 4 of these colors, so gray is right, green is posterior, left is blue, anterior is red, they're going to be all on top of each other. So this is a very symmetrical sphincter, but it's easier to see that in your numbers when you see your report in your numbers. Okay, so we do our squeeze duration. Your job here, just really make sure that your box is big enough. And then our next measurement is our squeeze duration. So we're going to ask our patients to squeeze and hold that measurement for 30 seconds. So always start your measurement before you ask them to squeeze. And here the patient squeeze, they have a pretty good effort here, but you can see that they fatigued, they re-squeezed, they fatigued, re-recruited, squeeze, re-recruited. So squeeze, relax, squeeze, relax. So this patient had a hard time maintaining that squeeze. So the squeeze duration is 1 squeeze that I recommend that you double check the computer on in line tracing. So I turn off my color and I magnify this tracing so I can see it better. The squeeze duration is only going to be measured in channels 1 and 2 because this is where the majority of the external anal sphincter muscle is. So if I click on this magnification tool that's called magnification tool, it's the first magnifying glass. I click it once. Now I bring my cursor down. It looks like a magnifying glass. I bring it to the upper left-hand corner of my yellow box and I click and drag it. Oh, I screwed up. Sorry, let me redo that one. Mouse here. Okay. So I'm just going to magnify diagonally. So now I'm going to magnify this whole box so I can see it a little bit better. So what the computer's doing here is looks at what the resting pressure is. And then it looks at the peak squeeze pressure and it draws a dashed line at the 50% of the initial squeeze pressure. When your waveform drops below that dashed line, that's fatigue. So, so the patient kind of fatigues here, tries to re-recruit, but it has to stay on that dashed line and kind of hover around it for the end of your squeeze duration. So this cursor needs to be where the patient fatigues and it stays down there. So this one right here, I think I might move it right here because it's kind of hovering around the line. So you kind of put your bias on this one. This one I would move over here, this cursor over here. This patient, they kind of fatigued a little bit, but then they're maintaining it for a long time here. So sometimes I'll tweak these squeeze durations a little bit because if the patient just momentarily lost their concentration, the pressure would drop below baseline, but then they say, ooh, I need to keep squeezing. The computer will put the cursor here, even though they maintained it for a longer time. So double check this measurement. So they should maintain the squeeze for 30 seconds. This patient only held it for about 4 seconds. So this is an early fatiguing squeeze. So there may be some pudendal nerve damage to this when they can't hold the squeezes very long. let's see. So I'm going to demagnify, go to last view, which is the third
Excuse,
magnify.
excuse me.
Mhm.
How the computer can locate the direction of the anal canal with the anterior, posterior, lateral, right, left, right? Because
Yes.
the anal has no indicator for the direction.
Yeah, so on your catheter, each sensor has 4 sensors, or each level has 4 sensors built into it. And you
Yes.
can't see them, but they're left, posterior, right, and left. And on your catheter, there's a line, there's an orientation line on your catheter. That line needs to be positioned posteriorly, so towards the spine, to get the proper orientation.
So there's an indicator line. We should position it posteriorly.
Yeah,
Before
it's a dark, yeah, it's a dark black line. So
Yes.
line and
Yes.
line towards the spine. Okay,
We should be positioned posteriorly.
exactly. Yep, exactly. So if that line is posteriorly, then these 4 orientations are going to be correct. It's posterior, left, anterior, and right.
Thank you very much.
You're welcome.
Can I ask a question about the sensor outside the anus, the external reference sensor? Can you tell us what are the benefits of it?
Yeah, so the best benefit of that is it helps you determine the length of the sphincter, and then you'll know that you're placed in the right spot. So it's just a reference. So you'll be able to see your distal border of your anal canal. So when the color changes from blue to kind of a yellow or here, that's your distal border of your sphincter. So it's just for a position value. So you'll want 1 centimeter outside the body. That way you can see the distal border, and the computer will be able to calculate length of the sphincter. And the other thing you can use it for too is when the patient squeezes, you can see whether or not they use their gluteal muscles to help squeeze, because the fact that the pressure is down here, that means they were kind of squeezing with their butt too. Okay. Okay.
Does the length of the sphincter really matters? I think it's more related to the general habitus of the patient. Is it related to specific diagnoses? Is it helpful?
I think it's helpful a little bit. There's very little literature on the length of the anal canal, but we definitely know that the length of the sphincter of the lower esophageal sphincter is really important. They've done studies that showed when the sphincter is shorter, it's not as competent. But there's not much data on here. But I think probably the same holds true. Females, the normal is like 2.5 to 3.5. So if the sphincter is really short, it's probably not going to be as competent. It just doesn't have enough. I would just assume it's not going to be as competent. So we do make note if we see a short sphincter, but there's very little literature on it, but they say that maybe there's been some traumatic injury or whatever that could cause a shorter sphincter. But yeah, not much research, unfortunately, has been done on that. But we definitely report it if it's on a female. If it's less than 2.5, we'll say short sphincter length, whatever, and maybe it's contributing to the incontinence. Yeah. Okay. So, what's, it's not in this protocol, but what's, oh, they did, this was kind of right here. But the other thing that we need to do, it's not in the instructions, but we need to do a cough. So we do a cough and we should see increased interrectal pressure, and then the anal canal pressure should go up. So we should see increased pressure there. So that's the cough reflex. It's going to be an evaluation to see if there's any sacral nerve damage. So make sure you do a couple coughs to see if that reflex is present. And then we do the rare study. So with the rare study, again, I don't do much editing here because the computer does such a nice job with the measurement cursors, but make sure that your measurement is started before you inflate your balloon and that you annotated the correct balloon volume. So, we can see that the larger volume of air, the greater drop in rare that we see. So, and again, rare is just going to be rare present or rare absent. And then the computer, I'll show you, but we don't really, the computer, well, let me try this one. it's going to put an X, a measurement cursor on channels 3, 4, and 5 at the lowest value. So that's how much the internal anal sphincter relaxed. On channels 1 and 2, it's going to put an X at the external anal sphincter contractile reflex. So that's what we were talking about before. When the patient feels rectal distension, they contract their sphincter for a minute, for a second or two. Let me change my range. Hopefully you can see it on this patient. Let's see if I can see an example. Oh, I'm sorry. I'm thinking I have Z view here. Oh, it's hard to see, but can you see on this example with our simulation of, oh, maybe it's better on this next one. So when they put in 60, do you see this little contraction right there? Little contraction right there. This patient doesn't really have it. There's a little contraction right there. So that's the patient saying, ooh, I feel something. I better contract my external anal sphincter. So the computer will put an X on that little rise in pressure. And I'll show you on the report where that's documented. But so that's if the patient was lacking this and they had fecal incontinence, this is something we could do biofeedback training on. We would tell them, contract that muscle. When you feel rectal filling, you need to contract that muscle. So the computer will tell you the percentage of internal anal sphincter relaxation. Anything greater than 15% is a positive rare. So rare would be present. Okay, so let me go back to my color. Sorry. There. Try and get rid of this thing. Oh, sorry. Try and get rid of my lines. Okay, so now the next part of our study is our push. Okay, so when the patient pushes, this is another measurement that I want you guys to double check the computer with. The computer is so accurate. It does everything beautifully as long as your boxes are big enough that you started them before the patient squeezed or pushed. The computer is so accurate, but it can make a mistake on that squeeze duration and on the pushes. So with the pushes, I'm going to look in my line tracing again, and I'm just going to double check that the computer placed these measurement cursors correctly. So it's only going to be placing cursors on the very, very top channel, which is our interrectal pressure. So we see that the patient used their belly muscles correctly. They pushed from above, and then it's going to measure the external anal sphincter. So channels 2 and 1 from the anal verge. It's going to place an X where it sees the very lowest the most pressure change. I'm sorry, where it sees the most pressure change. So I'm going to magnify, oops, that's not the one I want, this one. I'm going to magnify that so you can see this a little bit better. Oh, that's too much, sorry. I'll try again. Okay, so here the computer sees the very lowest dip right here and here and here. So it's placing the X at the very, very lowest pressure. So this patient has a normal push. The pressures drop. If your patient had a paradoxical response, they're going to be squeezing instead of relaxing. So that X is going to be at the peak of the waveform where it sees the highest pressure. So just double check that the patient is really putting, or that the computer put these X's where the patient was really giving it the best effort. So the best effort is like in the middle of where the patient's pushing. So look up above here where the patient's pushing, and then just kind of draw a line down here and say, yep, that's where the X's need to be, like right about here where the patient is pushing. Some of your patients, when they push, what they'll do is initially they'll squeeze because they're trying to figure out which muscle to relax. So the waveform will go up, and then they'll say, oh, no, I need to relax it. So they relax it. And then you tell them, okay, relax. And then there's a rebound. There's a second spike. So it goes up, the muscle, it contracts, the muscle relaxes, and then there's a rebound. Sometimes the computer will place an X where it sees that first contraction because it was a higher pressure change. So you would need to move that X from here down to here where their best effort is, okay? And then double check your second push and just make sure that those X's are at the very, very lowest pressure, all right? Okay, so this is a normal push. So if it was a paradoxical, you're going to see positive where it says amplitude. They're going to be positive numbers because the patient increased the pressure and you would have a 0% relaxation. Okay. And then the next part of our study is we did the slow sensation study. So you're going to analyze when the patient first felt the sensation, the distension, the urge, and then the maximum tolerated volume. So, you were kind of mentioning, one of you was mentioning before about with Hirschsprungs and, you inflate the balloon, you don't really see rare. So when we get to this maximum tolerated volume, the patient only got to 100 here, but even when we do our slow sensation study, we see this internal anal sphincter. If you look at our bottom channels, we're still seeing this internal anal sphincter relaxing. So if look here too for some better idea. Here they're doing the compliance study. I'm sorry. So positive sensation, yeah. So positive sensation here at 60. But so anyway, during your sensation study, or if you do a compliance study, you're still going to be able to see that rare down here. So look at that too for help. So these guys did do a rectal compliance study. So they put 50 milliliters of air in the rectal stimulation balloon. They waited 30 seconds. And I'm going to go into this color for you to see that. Okay. So they inflated the balloon. They waited 30 seconds, and then they took an interrectal baseline measurement. Then they inserted another 50. So now we have a volume of 100. And they waited 30 seconds for the body, or the rectum to accommodate it. Then they took another measurement. So if you look at the pressure at 50, it's no higher than 100. So that means the rectum is accommodating that volume. Then they put in another 50. And again, the pressure didn't increase, but they stopped at 150. So maybe the patient didn't tolerate any more urgent need or cramping. So they stopped at 150, but the computer is just going to measure the difference in pressure over volume. And this should all be pretty much the same if it's a compliant rectum. Okay, so from there, we can look at our report. Okay, so the computer, since we have those 4 orientations, posterior, left, anterior, and right, the computer is going to make a graph for you. And then lower anal canal, it's 1 centimeter above the anal opening. And then we have 2, 3 is upper anal canal, 4 and 5 is upper anal canal. So typically you're going to find your highest resting pressure. So this is your anal tone at 1 and 2 centimeters. So at this particular patient, if you look at the average of posterior, left, anterior, and right, it's 67. So this is a nice normal anal canal. You can also look at symmetry at the highest pressure. So 71, 63, 61, 72, all very similar pressures. So this is a symmetrical sphincter as well. If you see pressures like around 20 or 15 or something, that would most likely, and the rest were around 60, that would be asymmetrical. We don't have any actual numbers. It's just kind of a gestalt thing, just kind of a general feeling. But if you see a significant change in that number, that would be asymmetrical. So then our next measurement was our squeeze. So lower anal canal, that's most likely where you're going to find the highest squeeze pressures because there's more external anal sphincter pressure there, muscle there. So here again at 2 centimeters, that's where the highest pressure is 233. That's really strong. Normal is greater than 100. So this patient has a really strong squeeze. Some of your patients with anal fissures or proctalgia fugax, you may see higher squeeze pressures on those patients, but I'm not sure what the upper limit is. I think we're kind of saying maybe 250. But don't be surprised on those patients to see some higher squeeze pressures. And again, very symmetrical, all 4 quadrants, good symmetry here. All right. So squeeze, this is just all external anal sphincter. So we usually like to see them be able to double resting. So resting was, this one was such a high resting resting 139. So they should have at least 139. So this patient, was able to double resting with that squeeze. So really good external anal sphincter muscle. And then the resting tone, by the way, that's predominantly internal anal sphincter. So then the duration of our squeeze, they should be able to maintain that squeeze for 30 seconds. This patient only maintained it for 7 seconds. So this is an early fatiguing squeeze. So as I mentioned before, maybe some pudendal nerve damage. But the other thing with this patient is he squeezed so tightly, 233 millimeters of mercury. I wonder if he just used up all his gusto initially with that really, really strong squeeze and was unable to maintain that really high squeeze. So I tell my patients, I give them an expectation. I tell them, pretend you're in the car on the highway. There's no exit for 2 minutes. You need to hold that and you have to go to the bathroom. So hold that squeeze till you get to the next exit. That way they know, they have an expectation that they can't use up all the gusto right away. They've got to maintain it. So, part of anal rectal manometry, it's all your instructions. Especially with the urge, the slow sensation, the urge, first sensation, maximum tolerated, you really have to be clear with them what they need to report to you. So duration is your squeeze duration there. Simulated defecation response, that's your push. So you should see negative numbers in your lower anal canal because the pressure should decrease. And then from there, it's going to be converted into a percentage. So we should see percentages greater than 0. Okay, so this is a normal push. Okay, and then from there, we have our squeeze duration. It's recorded again here. And it's also giving us our sphincter length. So this is a 5 centimeter long sphincter. So males have a longer sphincter. So I'm going to assume that this is a male patient, but who knows? So now you get these vector plots. So this is going to show you the symmetry. So concentrate mostly on your high pressure zone, which in this case is 2 centimeters. This is our resting tone. And our legend is at the top here. The top at 12 o'clock is anterior, left is at 3, 6 is posterior, and 9 o'clock is right. So it's going to plot the pressures on circles. So, and our range here is 100. So each circle vector is 20 millimeters of mercury. So that's 20, 40, 60, 80. So all these resting pressures are around the 80 vector. So this is a very symmetrical sphincter. They're all on the same circle. And then here's that was resting. So this is squeeze. So the same thing with squeeze. Here our range is 500. So each circle is 100. So that's 100, 200, a little bit more than 200. So they're all in the same vector, very symmetrical sphincter. This is the graph that I like. I don't look at those other ones, but again, you're going to concentrate on 2 centimeters. So here is lower anal canal at 2 centimeters. The red is our resting pressure. And our range here is 500. So this is 100 up here. So all these pressures here, this is about 60 millimeters of mercury. Posterior left, anterior right, they're all pretty much the same pressure, all a straight line across, very symmetrical sphincter, normal sphincter pressure. And then this blue is our is our maximum squeeze pressure. So the patient was able to double resting pressure and very, very symmetrical and normal pressures. This is 200 right here. So this is a really quick visual to say, yep, symmetrical squeeze can double resting pressure. Okay, and then this rectal pressure here, why is that there? I have no idea why this rectal pressure is here. I have no idea why it's there. And we don't even use these numbers. So our upper anal canal here, so this is now our rare, this is our rare study, rectal anal inhibitory response. So anything greater than a 15% drop is normal. This was the old protocol where we put in 10, then 15, 20, 25, all the way up to 60. The London protocol says now just start with 30. If you see rare, and it's good, it's present. But if you want to get a little bit better examples, you can put in 40 or 50 to see a bigger drop. but typically you don't have to do quite so many inflations if you see a really good rare with smaller volumes. And now this lower anal canal contractile pressure, this is that external anal sphincter contracting just momentarily before, as when it feels the rectal distension with rare. So any positive numbers here means that reflex kind of subconscious contraction there is present. If it wasn't, if all zeros, then this patient could benefit from the biofeedback. And then our rectal sensation data, first sensation, urge, maximum tolerated. They didn't do a maximum tolerated, I don't know why, but you're going to see your values here. So with London classification, they're saying that you need to have 2. So you have first sensation, urge, and maximum tolerated should be greater than 200. At least 2 of these should be in normal range to have normal rectal sensation. So they call each one of these a modality. So 2 of these modalities need to be normal for the patient to have normal rectal sensation. Okay. And we do have normals for this. These are based on Satish Rao's data. Okay, so rectal compliance. So this is, where they put in the different volumes of air, and it will plot on a graph. So if you have a compliant rectum, the slope of your graph from 50, 100, 150, it all should be just a very, very small incline. So this is a very compliant rectum. All right. So this was a normal study, but things you're going to look for is, so like if your patient presents with incontinence, things you're going to look for is, first of all, your resting tone. Is that tone greater than 50 millimeters of mercury? So if it was less than 50, maybe it's too floppy. Maybe that's what's contributing to the incontinence. If you had asymmetry, that's a keyhole defect. Maybe that's where the leakage is coming from. If your patient had fecal incontinence, you'd also look at maximum squeeze. It should be greater than 100. And again, it should be symmetrical. You would look at squeeze duration. Is it just so if they can they not hold it long enough to get to the toilet? Okay, with our continence patients, we don't really pay too much attention to the push. And also your patients with incontinence, they don't want to push. They're afraid that they're going to leak. So a lot of times you get a paradoxical push with a patient with incontinence because they're kind of squeezing, afraid that they're going to leak. So I don't pay much attention to push on the incontinence patients. So we're not going to really look at push too much. I'm going to look at sphincter length a little bit on my patients with incontinence. And if it was a female, it should be around 2.5 to 3.5, males or 3 to 4.5. Okay, and then I would look at sensation too on my patients with fecal incontinence, because they may not feel the presence of that rectal distension and may not make the moves to defer defecation. So if any of those would be abnormal, then you could probably report that low resting pressures and weak voluntary squeeze most likely contributing to patient's fecal incontinence. Okay, so you can say something like that. So if this patient had constipation, or if a patient had constipation, then what I would look at is I would look at resting. Chances are in a patient with constipation or the difficulty passing stool, the excessive pushing, chances are they're going to have a normal resting pressure, but sometimes it's going to be low because they have spent a lifetime pushing, compressing the pudendal nerve when they push excessively for a long time, that they could have pudendal nerve damage and muscle weakness. So, you will see sometimes low pressures on patients with their constipation and difficulty passing stool. Same thing with maximum squeeze. Sometimes you'll see a weaker squeeze just because of the pudendal nerve damage from excessive pushing. Okay, so squeeze duration, same thing there. Normally you're going to see a normal squeeze duration on your patients with the paradoxical pushing, constipation. Okay, but what I really want to pay attention to with them is the simulated defecation response. That's your push. We should see negative numbers. That pressure should drop, and we should see positive percentages of drop. Okay. And then if you did see if you did see a paradoxical response, you're going to see positive numbers here, and you'll see 0% relaxation. Then if you wanted to, you could categorize that as paradoxical, and then you could call it a type 1, type 2, type 3, type 4, because that will help you with your biofeedback. You know, do you need to teach them to push from above better? Do you need to teach them to relax their external anal sphincter? You know, so you'll be able to teach them what muscles they need to work on if you classify it type 1, type 2, type 3, type 4. And then rectal, then obviously a patient with constipation, you're going to worry about your rare, you know, are the ganglion cells present? So you're going to look at your percentage of rare. If 15% or greater is rares present. Okay. And then sometimes on your patients with constipation or dyssynergia, you're going to look at sensation too, because this will help you determine whether or not they have a megarectum or something else where they're not having the signals that it's time to go to the bathroom. So you'll report on their sensation as well. Okay, and then patients, you know, pre-surgical for a colostomy, takedown, you're going to make sure that they have good resting and good squeeze measurements. If they don't, then they could maybe benefit from some biofeedback prior to their surgery and afterwards as well. Okay, questions?
When you should send for defecography, what are the information that are given by the defecography and not present in manometry?
Oh, I'm sorry. You cut off on the very, very beginning. I'm sorry. Can you repeat the question?
When should we send for defecography? What are the information that are not present in manometry or biofeedback, and we want to get it from defecography?
Yeah, you know what? I think defecography is more accurate. So I think, you know, when you did your manometry study, if it was just kind of questionable, I would do the defecography and see what those results are. I think they're definitely more accurate because, you know, you actually insert, you know, some, you know, mucil-like substance into the bowel, and they're sitting on a commode, and you get the video look at the whole dynamics of the pelvic floor. You'll see the puborectalis muscle relax or contract. You'll be able to see the kind of that stool coming down. So you really get a more accurate view of the anatomy and the physiology. Also, I think it's more physiologic because the patient has some substance there that they have to try to evacuate. So I definitely think it's more accurate. So when you do the manometry and you're asking your patients to push, they're in a recumbent, you know, they're laying on their side. It's not a normal defecation position. There's nothing in the rectum. Also, when they push down, are you really seeing relaxation of the sphincter, or is the catheter moving a little bit? So, you know, I just kind of think, you know, when you ask your patients to bear down and you see increased pressures, paradoxical, I think that that's really accurate with manometry. But sometimes if you see the pressure drop a little bit, sometimes I think it's catheter artifact. I think you're pushing and the catheter is moving a little bit, or the pelvic, or it's just moving outside your sensor a little bit. So for that reason, if you're pretty convinced that your patient has dyssynergia, but you see decreased pressures with manometry, I would definitely do the defecography. Yeah.
Excuse me, actually the difference between defecogram and manometry, rectal manometry, is like the difference between barium swallow and esophageal manometry. This is a visualization of the structure of the anal canal and the movement of the anal canal during defecation. It is most beneficial when we can visualize the mucosal prolapse syndrome.
Exactly. You really see the anatomy so much better.
Cannot be seen by manometry. Maybe some other abnormalities can be seen, like puborectalis movement, like esophageal study, barium study. This study, it is complementary for studying the anorectal area.
Yeah, exactly. And the barium studies are nice too, to look for the megarectum and
Yes.
yeah, and other complementary studies are like the SITS-mark studies for colonic transit. On your patients with constipation, you want to look at the colonic transit time. So that's good for them. Yeah, so a lot of complementary studies can be done.
It is a complementary to manometry.
Yeah, exactly. Yeah.
Can I ask about esophageal manometry?
Sure.
If someone have an operation for achalasia, and I want to assess the response, is there any criteria that I should say this is successful, this is not successful?
Wow. Yeah, I think the fact that the lower esophageal sphincter is normal, there's no pressures in the LES. Or minimal pressures. I think that would say it was successful. I think the other thing is to look at the bolus transit, because your catheter has the impedance on it, the bolus transit. And if they're clearing those liquids and they're clearing, I'm not sure if you're using the thicker viscous solutions or not, but if they can clear the viscous and the liquid, I think that you could say most likely successful. When they do a myotomy or a poem or whatever, they're opening up the sphincter. With a poem, they're actually cutting, the muscle in the esophagus. So you'll never see the contractions. The neurons are dead. You'll never see the contractions come back in the esophagus, but hopefully the LES is minimal pressure in the LES. I think that's what you can report on and just say, I'm not sure you can say successful or not successful, but at least you can say, LES pressures absent or minimal or whatever. And I think that by stating that, and you could say complete bolus transit, I think by just stating those two things, then indirectly you're saying that the surgery is a success. But I don't think you could put your credibility on the line and say it's a success or whatever, but you can just report the facts. My husband, Don Castell, he would always say, don't overdiagnose, just kind of state the facts. So just report what you find, like, minimal LES pressure or LES pressure, 5 millimeters of mercury, something like that. Complete bolus transit or normal bolus transit. I think that's what you report. And then the surgeon can make you can kind of go from there and make an assumption that it was a success. But I don't think on your report that you'd want to say surgery is success. I think you just report the fact. Do you know what I'm trying to say? Okay, my husband said it so much better. Sorry.
But sometimes the surgeon will blame the peristalsis in the esophagus for the bad bolus transit rather than the operation. How can we? Sometimes the indication of sending the manometry is whether the operation is effective or not.
The first part you said, the surgeon said what about the bolus transit? I'm sorry.
Because as you know, there's two parts in achalasia. There is peristalsis in the esophagus, and there is poor relaxation of the lower esophageal sphincter. So if the bolus does not transit, maybe it is because of peristalsis rather than the lower esophageal sphincter alone.
Yeah, that could be true. That could be true. Yeah. So, but with achalasia, you definitely, especially with type 1, you see that aperistalsis, but typically you see a tight sphincter typically you find a tight sphincter with them as well. And then type 2, you have that panesophageal pressurization and a poorly relaxing LES. But but when they do the surgery though, they're just really concentrating on the LES. I mean, you never maintain those contractions again. Yeah, I'm not sure. I don't know. I'm not sure.
Actually, the manometry after achalasia surgery sometimes indicated when manometry didn't do before surgery, and the patient is still complaining.
Yeah.
As you know, there's some like type 1 or type 3 not benefit from surgery because of
Right.
loss. Type 1 is decompensated achalasia. There's no peristalsis, although what is called a sigmoid esophagus, and the type 3 is a vigorous esophagus. Spastic it is a dysmotility problem, spasm. Type 3 may benefit from esophageal resection with
The poem, yeah. So
but
they
type 1 even no benefit from surgery at all. As you know, achalasia, it is incurable disease.
right, exactly.
Surgery is only palliation. So sometime when surgeon did surgery before manometry and patient still complaining, they send the patient to manometry to see what is the problem. But the problem is he didn't do a manometry to classify the achalasia before
Exactly.
surgery.
Yeah, that's really tragic. I mean, that's really, really sad. Yeah, that's sad when that happens. And unfortunately it does happen that they have surgery before, but then manometry, I guess, could be useful afterwards, because if they do have any peristalsis in the esophagus at all, let's say they just did a myotomy, and of the sphincter, but they didn't really cut too much of the esophagus, and you still see contractions, then that was, yeah. And the patient did not have achalasia. But and also with your point about that type 3, that is like the hardest one to treat too. That's the hardest one that gets at least, benefit from any surgery. It's the hardest one. And type 2 and 1, they both do well with balloon dilatations and myotomies, yeah. But on the other side too, a lot of time, every once in a while you'll catch a patient where they had a fundoplication but no manometry prior to it, and then they come back later with terrible dysphagia, and they have complete aperistalsis. So you don't know what happened. Did they have aperistalsis before the surgery, or was it because of the surgery? And why wasn't a manometry done before they did the fundoplication? So it's, yeah, tragic when you see that kind of stuff happen, because can't get it back. That anatomy doesn't come back.
Do you receive the patient from outpatient clinic, or you are so specialized in manometry, so you only do manometry? To ask the next to know whether I should ask the next question.
Yeah. Okay. So yeah, I just see right now. I used to be a GI nurse a long time ago, and yeah, we worked with surgeons and gastroenterologists and all that kind of stuff. But so now I'm just totally specialized. I just do manometry, and I see patients in outpatient or clinics, and also in hospitals. But yeah, I don't really deal with that. Well, and I see surgery patients and I see gastroenterology patients, but yeah, I don't deal with the in-house stuff so much. And yeah. So
but I will ask my question anyway.
Okay, good. Okay.
In the books, the management of constipation, they said just give laxative or something like that, and the next step right away to the manometry or the phygography. We think it is too early to do that in the clinical practice, in real life practice. In the US, when is the manometry? When should we do it? Is it do you really apply the guidelines which stated that you should do manometry right after a simple trial of fibers and lifestyle modification?
Yeah, you know what? I think that in the patients that I see, I think obviously, yeah, they do all the fiber and the medicines and all that kind of stuff. And I think probably 90% of my patients have a colonoscopy prior to the manometry, and then they do the fiber and the medicines, and then the manometry kind of comes after all that if they fail the treatment. Yeah. I
see.
Yeah.
Another question. Sometimes our patient says that I have a terrible dysphagia, and we face a normal esophageal manometry. So if we give the patient solid, not liquid swallows, we don't do that, to be frank. But what is your experience in that? Can we get anything from that? Do we benefit our patient? Is it harmful to the probe?
No. No, and I know a lot of people do solids studies. Some people do solids. They have their patients bring in food that their typical foods that get stuck. So they'll have their patients bring those foods. Other people will do graham cracker or saltine cracker. They'll eat crackers. I don't do it in our lab because there really hasn't been, I don't think, any real standard normal values. But I think what they're looking at is like the whole entire time that the patient is swallowing, the lower esophageal sphincter should be open while they're swallowing. And I'm sure they look at the peristaltic contractions as well. But I think they're mostly looking at the LES relaxation should stay open. And then I'm Dr. Dr. John Pandolfino. He's written papers about the solid swallows. You might be able to find something with his literature. Yeah.
Can I ask another question, please?
Yes, definitely.
And the software of the esophageal manometry, how can we tell the length of the hiatus hernia?
Oh, yeah, that's fun. Let's see. Let me bring up a. I have too many patients. My computer's slow. Let's see. Okay, so this patient has a really tiny hiatal hernia, but so to determine the length, you're going to set these probe bars, and the top of your LES, this white bar here, if I put my mouse on it, you're going to set that black line kind of where the the colors turn blue to yellow. So that's the proximal border of your LES. And then the distal, I'm going to put my bar on the distal LES. And so that's kind of where green meets yellow here. And then so this is my LES. Then I have a small gap right here, which is the hernia. And then this other high pressure zone is my diaphragmatic pinch. So I'm going to put typically, oops, the EGJ probe bar is right here. So I'm going to move the EGJ bar down to the bottom of my diaphragmatic pinch. And then the the diamond, that's going to go where I see the strongest pressures inside my diaphragmatic pinch. So where I see it the reddest. And then the diamond of my LES goes where I see the highest pressures of my LES. So now I'm going to tell the computer where the pressure inversion point is, so where the diaphragm is. So I'm going to put my arrow on this PIP bar. I'm going to take it all the way down to the stomach. And now I'm going to very slowly move this up. I'm looking at two channels a centimeter apart with respirations. They're both, the blue and the pink are still going up together. But right now the pink goes up and the blue goes down. So that means everything below my white bar is abdominal, everything above it is thoracic. And if I look at my values here, it's telling me now that the intra-abdominal length is 0.5 centimeters. So this is a really tiny hernia, 0.5 centimeters, and that the EGJ morphology is a type 3. So that means there's separation between the LES and the hernia and the diaphragmatic pinch. Type 2 is the diaphragm would be right at the bottom of the LES, and then type 1 is normal. The diaphragm is in the middle of the LES. So did that answer your question about the hiatal hernia?
Of course. Thank you.
Yeah, if you have a patient with a large hernia, I thought that this patient was, I think I have another example here. Let's see. This is a hernia. Hernia. Oh, I don't want to review reports, sorry.
You mean that you determine the proximal border of the lower esophageal sphincter and the distal border of the lower esophageal sphincter by inversion, pressure inversion point. And with the computer will calculate the distance or the length of the lower esophageal sphincter from
Exactly.
Inversion pressure point.
Right, exactly. Yeah, and I'll show you that again. So that this patient has a larger, can you guys appreciate this patient has a larger hernia here? So I would set my proximal border kind of where
Yes.
yellow. Yep. And then the distal. So
the distal will determined by inversion point.
Yeah, good. And then so my EGJ junction is going to go to the bottom. Okay, and then the triangles, I'm sorry, the diamonds. So the line will be where the highest pressure is. Okay, and then to determine where exactly the diaphragm is, we're going to use that pressure inversion, this bar here. Okay, so we'll take it all the way to the stomach. Okay, and the yellow, I'm sorry, the pink and the blue are both going up, 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 up. So right here, it just almost looks like a diamond. So one, the pressure goes up with on the abdominal side, goes down on the thoracic. And then if you look at your values here, so now, so proximal LES is at 39.5. So if you were going to do a pH study on this patient, impedance pH, you'd place your catheter 5 centimeters above that. So 35 basically. So your distal LES is at 41. So now the computer will tell you that the LES length is 2.2 centimeters. And then this hernia is 3.1 centimeter. Oh, I'm sorry. Intra-abdominal length. So yeah, the 3.1 centimeter hernia is this one. Intra-abdominal length. No, I'm sorry, it's a 1.7. I'm sorry, intra-abdominal length. So this is a 1.7 centimeter long hernia. You look at the intra-abdominal length. Okay.
Excuse me, what is the difference between the two? What is the intra-abdominal length and EGJ relative to lower esophageal sphincter? What is the difference between the two numbers?
Yeah. Okay. So so intra-abdominal length. So that is so from I think the distal border of the LES to where the diaphragm is. So that's just all hernia right here. The EGJ relative to the LES. So I believe that's from the top of the LES to let's see, where is that? So I think it's
it doesn't make any sense because by definition, the hiatus hernia is part of the stomach inside the chest. How does the intra-abdominal length represent the hiatus hernia?
Yeah, is it going from diamond to diamond? I think it might be diamond to diamond. Let me think about this. 1, 2, 3. Yeah. So okay. So I'm almost positive that the EGJ relative to the LES, it's where the high pressure zone of the LES to the middle of your diaphragmatic pinch here. So basically from diamond to diamond. And each one of these green boxes is a centimeter. So that kind of jives here. So that's 1, 2, 3. So yeah, so EGJ morphology from middle of LES to basically middle of, I'm sorry, EGJ relative to LES, middle of LES to middle of your diaphragmatic pinch, your intra-abdominal length, that's basically the size of your hernia right here, which is almost 2 centimeters. Okay. Yeah, and for whatever reason, the Chicago people feel that, when you calculate your LES relaxations, so your LES relaxations, if the patient has a hernia, you need to incorporate with your IRP measurement the LES, the hernia, and the diaphragmatic pinch, because they feel like all 3 of those play a part in the LES pressure and the relaxation. So that's why this measurement incorporates everything from top to bottom.
Can I ask you about a specific patient we faced a day
Sure.
before?
Sure.
The patient have a DL, which is very low, I think 3 seconds. So we thought it is achalasia type 3. But when we saw the DCI, it was very high. It is 9,000. So what should we consider this patient? Is it a jackhammer or is it type 3 achalasia?
Wow.
The IRP was high, but not that high, 22, I think.
Okay. Okay, so that's borderline. And then you said the distal latency was 3, you said?
Yes, the distal latency was low.
Wow.
2, 3. Yeah. So we
Yeah.
were confused. Is it achalasia type 3 or is it jackhammer esophagus?
Yeah, and it could even be distal esophageal spasm too, right? So how many were all the contractions over 9,000? DCI, every one of them?
Not all of. I can't remember. I'm sorry,
but some of them,
half
at least 2. Okay, so at least 2. Okay. Yeah, we would yeah, it could be really 3 things: jackhammer, DES, or type 3 achalasia. So in those cases, let's see. In those, what was the patient's symptoms? Was it dysphagia or chest pain?
Dysphagia, not chest pain.
Okay. Okay. So
excuse me. Anything above 8,000, it is a jackhammer. The difference between jackhammer and the achalasia, vigorous achalasia, is the DL, distal latency, because distal latency in achalasia will be very short because of loss of peristalsis. There is no propagation of the bolus. So the difference between achalasia, vigorous achalasia, and type jackhammer esophagus is the DL, distal latency. It was,
so George, if you look at the guidelines, once the IRP is high, we should go to the side of achalasias. So
exactly.
yes,
Yeah.
yes, sure. But
how can you explain the high IRP?
Yeah. So, on a patient like this, it really has a lot of characteristics. I think they also suggest that you do some further evaluation, like with a flip or a time barium swallow or some other barium swallows to kind of help with that diagnosis, because that is like a hard one. He really does have a whole bunch of things, but the fact that his LES doesn't relax, that kind of puts him on that achalasia spectrum. But there's other things that will give you a high IRP, and that is a hiatal hernia. You can get a little artifact from the catheter. What else? If patients are on opioids, that can cause a poorly relaxing LES. There's 5 things. Sometimes there's, what are the other 2? Obviously, they could have EGJ outflow obstruction. So they say sometimes sometimes if you really want to clarify that poorly relaxing LES, they do have to have a symptom of either chest pain or dysphagia. And they also say to, kind of verify it, or, kind of help with that gray area with that flip or a time barium swallow. So on that patient, yeah, that might help, since he's, he's kind of, Yeah, borderline.
Excuse me, in jackhammer esophagus, there is a peristalsis, but it's a very vigorous contraction with peristalsis. There is a propagation of the peristalsis, but in achalasia there is no propagation. There's loss of peristalsis. There's in jackhammer there is a vigorous peristalsis. And vigorous contraction, but the peristalsis is preserved. In achalasia, by definition, the achalasia is defined as loss of lower esophageal relaxation with loss of esophageal peristalsis. This is the definition of achalasia. So the distal latency is the point that difference between vigorous achalasia or gastric gastroesophageal outlet obstruction and achalasia.
Thank you.
In cases of achalasia type 2, should we delete the DL? Because once this computer measures the DL, and it is usually on the low side, the computer will conclude that this is achalasia type 3. So if we saw the pan-esophageal contraction, should we measure or we shouldn't measure the DL?
That's a good question. I keep mine in. But then I make sure though that the interpretation says pan-esophageal pressurization, but I keep it in there. But just make sure that make sure that you override the computer and type in pan-esophageal pressurization type 2 achalasia, whatever.
This is the point that differentiated from vigorous achalasia. There is a pan-esophageal pressurization. The pressure looks like vertical because of very low DL. In achalasia, it should be very low DL, below normal.
Yeah. Let's see, I think we have a type 3 here. Let's see. Oh, shoot, I thought we had a type 3. I don't see it. Shoot. Okay. Type 1, type 2. Shoot, I thought we had a type 3. We don't. I'm sorry. Shoot. Okay. Yeah, and if you look at this too, this will give you this one right here. The distal latency is 5.5, because but like you're saying, it's really kind of inaccurate. This is really, this kind of reflects really that pan-esophageal, kind of.
You can apply it to the next swallow to represent my question.
Yeah.
The DL is so low.
Yeah, it's really low here. Yeah. But this is, and the computer does. I know, because I've caught it too. It will call, sometimes it will call EGJ outflow. It will call type 2. Sometimes it will call it EGJ outflow obstruction. And obviously this is a type 2. So just double check that computer, because it will make a mistake on EG outflow obstruction sometimes, and on type 2 achalasia it will make a mistake. So just double check it and override it.
What about the upper esophageal sphincter? In the steps of manometry, they requested, and we spend a lot of time on it. Is it really very beneficial?
I think it is on patients who have globus sensation or neurological conditions like Parkinson's disease or myasthenia gravis, or I think it is, but mostly for the patients who have the globus sensation, because I just really want to make sure that that there's good coordination and that the UES isn't too strong, too hypertensive. So yeah. So on those patients, I do look at the UES and we do make comment on it. So we want to see that pharyngeal contraction occurring during the UES relaxation, and we want to make sure that that UES relaxes with a residual less than 8. So I think on those patients it's beneficial, but on the average pre-surgical patient or patient with dysphagia, yeah, and in my lab, I know other people will think differently. They want to measure every one of their patients, but if you really suspect a UES abnormality, there's better fluoroscopy methods of looking at the UES, I think. But yeah, I think it's helpful and I think it's good. We kind of eyeball it as we do our study, and I'm not sure if my physicians will do the interpretation, and I'm not sure really how much they say about it. I don't know, but we do. I know for sure we do mention if it's hypotensive, because if it's hypotensive, I mean that's really important, especially on your patients with dysphagia or IEM, ineffective esophageal motility. You want to make sure that they have a competent UES. So we do mention about the resting pressure of the UES, but we don't really talk too much about or report too much about that pharyngeal UES coordination unless it's the globus sensation. But yeah, but I'm sure it's helpful. I'm sure it's helpful. And yeah, we used to, way back when I first started doing manometry, we spent a lot of time with the UES. It just, and when I do my teachings and go around the country, very few physicians really pay much attention to it. And I don't know why they're not looking at it so much anymore. I'm not sure why. Yeah, sorry, that was a wish-washy answer, sorry.
And lastly, can we get your email so that we can discuss difficult cases with you if you don't?
Sure. Let me type my email on the screen here.
Maybe in the chat?
Yeah, I'll get it to you. Hold on a second. No. Hold on one second. Let me just get it to. Okay, so. Yeah, so that's my email. Feel free to email me if you want any of those. If you want me to send you that lecture that I used this morning, I can do that. Or if you have any questions, feel free to call me, or not call me, but email me. You could call me too, but our time difference is so different. I wouldn't answer.
Thank you so much. We won't bother you by calling, of course, just by email. I even maybe I will export the study to see it just like I saw it.
Yeah, that'd be interesting. Thank you. I'd like to see that. Well, I enjoyed this session. You guys had very, very good questions. You made me think.
That's the question. Do you think a flip is necessary in our country to make it available? And the same question about the ethicography. Is it that important? Should we work on that? How many patients would get benefit from that test?
Yeah, I definitely think ethicography is really, really important, especially, on your patients where, they have that excessive straining, you think they may have a prolapse. On your constipation patients, I think it's very, very, very beneficial. I don't
CT or MRI or barium.
Oh, the barium. Oh, I don't have any experience with the MRI, but I hear it's awesome. Yeah. So if you have accessibility to it, yeah, definitely the MRI over the barium for sure. And then I don't have any really hands-on experience with the flip, and unfortunately none of my physicians are doing it right now, so my only knowledge is what I've heard from the literature. But I definitely, it sounds like it's beneficial on your patients with the EGJ, suspected EGJ outflow obstruction, and with your patients with achalasia. Yeah, I think it's really useful, and I from what I've read, And I think it's a nice complementary procedure with manometry. But I can't give you any firsthand experience and how people are when they get the findings, what they're doing from there, because unfortunately, none of my physicians are using it right now with my docs.
Regarding the reference range, the article that you referred to, we couldn't find it online. Can you please send it or just
Which thing? Which online? Which link? For what?
I think this is the first question I asked you about the normal ranges, and you mentioned some name.
Oh, okay. Okay, I'll tell you what, email me and I will email you the article. Okay. Yeah.
Thank you so much. It's so beneficial.
You're so welcome. You're so welcome.
Bother you a lot with our question.
Again, thank you so much, Linda, for your time, and for the Iraq team. I hope that you find it very helpful with Linda experience. Over 35 years of experience is very indelible for us, Linda. So thank you so much.
Appreciate it. Thank you.
Thank you, Ms. Linda.
Okay, well, have a good evening.
Have a good evening, everyone. And you have a great day, Linda.
I will. Thank you.
You're welcome.
Bye-bye.
Yep. Bye-bye.